Good morning. Welcome. This is the House Study Committee on evaluating funding for public health. And I would at this time like to ask Representative Dexter Sharper if he would open us in prayer.
Just want to say quickly, I'd like to thank Dr. Markings, who's our medical director over South Health District in Valdosta. He actually made the trip to be here. So it's good to see that. I appreciate you coming and being a part of this today. Let us pray. Heavenly Father, we just thank you for this day that you've made, God. We just ask you to look on us, God, as we do the business of the people, God. We just thank you for everybody that's made it here, God. Thank you for the traveling mercies. God, we ask you just give us the wisdom, knowledge, and understanding that we need, God, to help others and serve others. In your precious name we pray. Amen.
At this time, I would like each of the members of the committee, we'll start with you, Dexter, to tell us where you're from, a little bit about yourself.
My name is Dexter Sharper. I am 13 years here so far from Valdosta, Georgia, District 177. Also, my medical background is I've been a paramedic for 35 years, and I still have my license. And I'm here to really do everything I can to be a part of this committee, and I appreciate being a part of this committee, but I'm just a person that loves people, and I love to serve. Thank you.
Thank you. I'm Darlene Taylor. I represent District 173 in Southwest Georgia. I live in Thomasville. I serve on a number of committees, including appropriations for healthcare. And I'm appreciative of everyone's interest in this important issue. And I look forward to finding a lot of information and looking for maybe some solutions. Thank you.
I'm Matt Hatchett. I represent District 155, Lawrence County and Johnson County. And since Representative Sharper introduced his doctor, I'll introduce my doctor we'll hear from later. Dr. Thomas Craft, he's the district director from the South Central District. I guess he came up this morning and battled traffic probably, but glad to see you and look forward to working with everybody on this issue.
Good morning. I'm Angie Osteen. I'm not the caboose this time, Chairman Hatchett. But I am the newbie. I just got elected. This is my first session that I just made it through. Woo-hoo, I'm so glad I made it through it. I represent District 169, Coffee, Irwin, Turner, Tift, very rural. My family and I farm, and I have been a registered nurse since 1997, though I haven't practiced in several years. I've been a perpetual volunteer, which is probably why I got here. But I'm excited to be on this committee too. It's great. Thank you.
Good morning. I'm Butch Parrish. I represent District 158. I live down in Emmanuel County. I'm a retired pharmacist, and I understand rural health care and the need for the public health department and the services they provide. I'm glad to be here and look forward to hearing what our presenters are going to talk to us about. Thank you.
Thank you. Again, I'd like to take this opportunity to thank the members of the committee and our presenters today. We will be hearing from those who work in and with our state's all-important public health agency. I'm looking forward to an open and informative discussion, and that's what it will be. I imagine we'll have a number of questions from the members of the committee as we're looking to help. We want to find ways that we can be of service to the people of the state of Georgia. Some believe that public health has historically been underfunded, specifically when compared to healthcare and other areas in general. In fact, less than 1 in every 10 state dollars funds are spent on Georgia's 3 primary healthcare agencies. So we're looking forward to a lot of good information. We'll be studying how Georgia's public health system is structured and how it's funded, and what services they do. And we have discovered so far, if you've seen one health department, you've seen one health department. So we're really looking forward to it. And I can't wait to hear everything y'all have to say. And I would like to see our first presenter, Dr. Toomey, if you would come forward. Thank you. Yes, that would be perfect.
Telling you that you have to spring me in my parking pass had not been updated, and you couldn't get in. We were trying to argue that we were actually legit and had a very important business to do with the company. But
we're very glad you made it, and I can't help but recognize Chairman Cooper. If you would introduce yourself, we're very happy you're here today.
Oh,
Thank you very, very much, Madam Chairman. I'm not a member of the committee, but of course, public health is near and dear to my heart. So I'm State Representative Sharon Cooper, Chair of the Community and Public Health Committee in the Georgia House.
Thank you. The floor is yours.
I will try very hard to keep within my 30 minutes. And you think that you gave me an easy topic as to what is public health. And that's probably the hardest thing to answer in a simple way. Even my own mother couldn't figure out what I did, because I would start to talk about epidemiology and disease outbreaks and treatment and prevention for disease and working at the community level. And it's not as easy to understand as healthcare when you go into a doctor and get treatment. And I think without that clarity, we sometimes have trouble having the public recognize the importance of what we do at the community level. What's interesting to me, and I spend a lot of time talking to my peers in other states who have my position, and including those significantly younger than me, many of them started out, like I did, in primary care. And we start out in primary care, delivering care. I wanted as a child to run a mission hospital in Africa. And I ended up running a hospital in the Arctic instead. And I don't know if you all know this. I may have told some of you this story, but it was up there as I was caring for a 50,000 square mile, very rural area in Northwest Alaska and delivering babies and taking care of all aspects of health in the community, that I realized that a lot of the babies I was taking care of had eye infection, even though we were giving prophylaxis, which was then silver nitrate, and also developing pneumonia during the first months of life. And I said, that's really weird. Now, this is so long ago that we didn't have easy tests for chlamydia in the Indian Health Service hospitals, which is where I was. But being an astute clinician, I said, I wonder if this could be chlamydia affecting these kids and potentially affecting the moms and affecting their later fertility and having an impact on the community as a whole. Well, I was able to work out with my residency the ability to do tests. We had the community health workers in that region. I taught them how to do the exams and do these tests. And what we found, much to everyone's surprise, including the folks from the University of Washington, is that 25% of women in the region had chlamydia and 30% of the pregnant teens. So this is why we were seeing babies with chlamydial disease, eye disease, and pneumonia. So why am I telling you this story, which is the story of kind of how I moved into public health? I realized what really was exciting to me was being able to practice, but also to practice at the community level, to see that taking care of an individual patient is so important, and certainly so important to that individual. But if you look at the community as a whole, as I was doing, because I basically ran the health system for a 50,000 square mile area, you can have a tremendous impact on the health, that community. And we went on to do other things in preventive care, including expanding pap smears and improving prenatal care and all that work, which I think was a precursor to my interests in all the work that we're doing now in DPH. But the reason I'm telling you these stories about myself is that this reflects kind of a real sea change for me, who was determined to be working in a traditional medical care facility. And I just realized at the time, as did many of my peers in the other states, that the real change in health status at the community level is going to come from that public health intervention that will help improve our ability to keep people healthy and well. So that is not a good elevator speech, I know, to explain what public health does, but it focuses on prevention, protecting and improving health of communities, health promotion, populations rather than individual patients, and yet that those interventions at that population level will clearly improve the health of all the individuals in the community. What are the components of public health? Disease prevention and control, including epidemiology and tracking, which I unwittingly, even though I wasn't trained to do it, or was doing it at the time that I was monitoring these babies. Vaccinations, and important to me, probably one of the most important public health achievements ever, because I practiced at a time we didn't have immunizations for many of these conditions. And I know what these conditions can do and how we can now prevent death and disability in kids through immunizations. Health promotion and nutrition, like the WIC program, which we are doing. All of this choreographed, across multiple disciplines that work together within public health to improve community health. One of the other things that I think is really unique about the work that public health in general, not just in Georgia, but in general does, is that we look at what we call the social drivers of health, and that it used to be called the social determinants, and that almost is as meaningless as the social drivers of health. But I think what we're saying when we use those terms is that there's more to health than just access to care. And if you don't have food on your table, if you don't have an ability to get to the medical care, then that is really one of the barriers to improving health in the community. And in fact, we have seen in our own programs that it's that transportation issue, even for women who have, for example, Medicaid access during pregnancy. That is the biggest barrier to their getting adequate care. And so public health then can move in and help work through some of these programs to ensure that women or kids or whoever in the community can get access to the services they need. One of the things that I wanted to raise when I did kind of some background work to think about what I would say to you, because you've heard me talk over many years, some of you more years than others, but I had no idea how long the federal engagement had been in public health. I've been so focused on the recent federal engagement and disengagement in public health nationally that I didn't realize the Public Health Service had been so active in Georgia in the early years, even before we had, certainly before we had a state public health system and county health departments. And that engagement included, for example, helping to build sanitation facilities and outhouses. I think that I would like to say that this is the precursor to our work in septic tanks and some of the other things we did, because there was a considerable problem with hookworm here in the South, and the U.S. Public Health Service came in to help with that. The Centers for Disease Control was actually the Communicable Disease Center that was established in Chambly, that malaria-infested location in Chambly. Seriously, because Georgia was an area that had malaria, and that the government was trying to ensure that our troops were able to go, and they were able to do disease control. So it was the Communicable Disease Center, eventually the Center for Disease Control, and ultimately the Centers for Disease Control and Prevention, the CDC itself, expanded the scope of what they were doing, which I have a few more words to say, because that has also reflected on our work. STD control, again, I had no idea that PHS was so engaged early on during World War I here in Georgia on STD work. And then in the 1950s, particularly around syphilis. And here we are, still talking about that. But it was a major effort by the federal government, and so that the work we're doing currently, as well as expanding into HIV, really reflects a sort of a historical perspective. Tuberculosis, another area where we had a lot of federal engagement, but also maternal and child health services, which is, I consider, our core, some of our core work. Many of these programs currently are federally funded, but they also have state funding, but they also reflect kind of a historical background that I was not fully aware of. State leadership at a board of health level, like sort of at a state public health agency level, was first created in 1875. But then it was disbanded 2 years later because the legislature cut the funding. So it sounds like there have been episodic changes as well. But by contrast, county boards of health were established in 1914. And from that came the health departments, which have really operated semi-autonomously from the state health department, which was created in 1903 and then changed over the years. I did not know this history. It's fascinating to me. I love history and thinking about how history actually affects our ability to work with and approach the future. But I think our unique structure, which I thought began with Governor Carter and DHR, I did not realize that that unique structure and that hybrid model was actually preceded that significantly. My personal engagement with the state public health was, with DHR. But, again, that hybrid model was far long before that. And this structure, and you'll hear a little bit more about our structure and function, is quite a bit different than other states in the South. And again, I engage with them quite a bit. So Mississippi, Alabama, Florida, South Carolina, and Tennessee, the counties report to the state. There's some pluses and minuses with that. I know, Madam Chairman, we've talked about billing and some of those things. The state can do the billing if everybody reports to the state. There can be consistency and consistent rules across all counties. There's less local control. So there's some pluses and minuses, but I think that's, certainly a topic of discussion. But of real interest is just given that the history of this went on much longer than I had realized. But has been largely unchanged for many years. Let me just take the few minutes more I have to actually talk about our mission for the citizens of Georgia, because I think that is absolutely important for us to emphasize what I think all of us here in the room who are from our agency reflect our commitment. And that's to what is the information we can provide in public health? To me, one of the core things we do is provide data and information. Epidemiology, which is not something that other agencies do, is really something unique to us. We provide the data about outbreaks. We provide the data about kind of rates of communicable disease. We also provide the description of what non-communicable diseases are doing. I recently worked on a pediatric cancer plan. I mean, that reflected pediatric cancer rates. That is something that public health, again, uniquely does, and particularly in recent years has moved into some of the non-communicable diseases area. I think we have, and I will brag about this, one of the best epidemiology units in the country. I'm proud that I started out as the state epidemiologist many years ago. And I think what has been built over the years is a foundation to allow the entire department to identify and react to a multitude of health conditions, whether it be infectious diseases or maternal mortality. Our public health laboratory is something you've heard me talk about before. And again, it's something that is really unique to our agency. Our public health lab does testing for things that no other laboratory, no commercial lab is going to do, including bioterror agents and other specimens that are collected during an outbreak. And I think that, again, this is something that isn't visible to the public, and I would love to take you there because it's kind of an interesting and exciting place. But it really is part of our foundation for that epidemiology work. I wanted to tell you about a couple of outbreaks, and I will talk quickly because I think that demonstrates how public health works in a different way, but in partnership with the healthcare system. A number of years ago, we got notified, the health department got notified of a large number of individuals who developed vomiting and diarrhea. They identified it as norovirus. They went in and did an investigation. And it turned out that all of these individuals had either attended parties or baby showers or weddings. And the one constant factor that they all had encountered was the cake. And so imagine if the person who was decorating the cake had themselves had diarrhea and had long fingernails. And at that time, we did not have the requirement that you wear gloves in food services. And in fact, if you ate the roses, you were more likely to get a larger unit dose of virus. And it was to me, it was so interesting because you had the medical community identifying, the epi team investigating, the environmental health, and along with agriculture, looking at, what the food might have been, and then coming up with, cakes and leading to long-term policy change, which was now gloves are required in food services. As you would think they might have been, but it took something like that to wake I think all of us up. One more similar thing, again, to show this choreographed approach, and some of you may remember this as it was made a great impression on me, and that was an outbreak that we had of E. coli 0157H7 in a water park in Cobb County. We kind of became aware of it when an Atlanta Braves player's child was actually hospitalized with hemolytic uremic syndrome, a very, very dangerous complication of E. coli 0157. We began the investigation. Again, it was choreographed with the epidemiology team, both at the state as well as in Cobb County, being able to look at how many kids were sick. My recollection is about 26 kids were infected, 7 hospitalized, 1 child died in this outbreak. And what they found was, and this was not, I don't think we actually fully appreciated this before, 0157 had been in hamburgers. I was telling everybody to cook your hamburgers, when you have your family barbecue. This was in the water at the water park. And kids at the time were coming in diapers. And I don't know how else to say this. So poopy diapers were the vehicle for transmission, and they just overwhelmed the chlorine system of the park. And what happened with this outbreak, which again I love, is that policy changed, not just here in the state and how environmental health inspects pools, but also nationwide. You'll see, kiddie pools now have little sprinklers. It's not standing water, and there's changes in how they look at the chlorination, because knowing that things can be overwhelmed. And all these components, work together in this choreographed way to ensure that this doesn't something tragic like this doesn't happen again. And I just, again, we talk about how public health isn't recognized until there's some issue. But there was no issue with the World Cup, that's knocking on wood, with all the football games we've had at Mercedes-Benz, and we've had many big national games. And that was, again, an orchestrated effort by public health to ensure the safety, and particularly the environmental health team, or what I'll call the sanitarians, because they're different than EPA. I want to just very quickly, because I think I have 5 more minutes, just hit a couple of other issues. These are all kind of things where I'm showing how we work together in a choreographed way, and how environmental health, or what we can call public health environmental experts, work together with our epidemiologists at the community level to ensure the public safety. But to me, and what I'm personally the most proud of in the years that I've worked with Georgia Public Health, is our DPH home visiting program. And the reason I say that is that it reflects exactly what public health should be. We took data that was developed by a team, both with clinical skills as well as epidemiologic skills, to identify where our poor outcomes were for mothers and babies, and looking then at those data as to what were those factors, and how can we work together to across all the disciplines, serving mothers and babies to be able to provide the services at the community level that's specific to that community. And I think that and if you look, and you will be seeing, I think, or at least hearing about this work, you'll see that it really is quite different from one county to another, one community to another, because it reflects the needs of that community. That's public health. And it's just really exciting to see that have taken off with your support. As I said, with the changes at the federal level, we have certainly modified and expanded our own work as well into the non-communicable disease area. And we've also been seeing changes in federal funding. But I think, as I've said to some of you several times, I think as we're seeing these changes at the federal level, it's giving us an opportunity to look at what is important for us. Because we often applied for grants that may or may not have been relevant. They weren't like home visiting. They weren't developed, with our state specifically in mind, with our data. We were following guidelines that were universal across every state. Every state's different. Every county is different in Georgia. And so it wasn't, all those federal grants may not have been as impactful as they could have been, had we kind of redesigned them with more flexibility. But I'm just saying that I think these changes at the federal level are giving us an opportunity to really reimagine what public health can be. I think some of the things that we do really well is work in partnership, not just with the broader healthcare community, certainly physicians, hospitals, others, but also, schools, churches, community groups. And I'll say the business community that was such an important partner to us after 9/11, certainly during COVID. And if we can kind of re-energize some of these partnerships and refocus, we'll be able to explore, I think, some really creative ways to improve some of these public health interventions at the community level that will really improve Georgia's ability even to attract business, because I can say good health is good business. And growing our business community, even as we're growing public health, I think are things that we can do hand in hand. And then finally, I'd like to say, as we look to the future of public health in Georgia, let's keep our eye on that mission. We focus on community level prevention. We literally touch every person at birth. Every baby born here has newborn screening. It may end up with a birth certificate from our vital records. We provide critical services. We provide outreach. We provide education. We provide health promotion. Our women's health care provides family planning in every county. I mean, we are really providing extraordinary service to the state as a whole, and yet often don't get recognized because we do a good job, frankly. I just wanted to close in my final minute with one of my favorite metaphors. And forgive me, Madam Chair, because you've heard me say this before. My favorite movie at Christmas time is It's a Wonderful Life. I just think it's really an amazing story, because I think all of us at some point in our lives think, oh my gosh, what have I accomplished? Well, like George Bailey, who wished that he had never been born. I think public health often thinks, what are we doing here? Are we having an impact? And I don't think it should take Clarence and Angel to come and demonstrate the value of public health to Georgia, because we have had such an impact. Imagine what Georgia would be like without public health. And we would have the kids without vaccinations, with outbreaks, literally killing Georgians of all ages. That without the kind of service we have at the level, without the home visiting, without all these preventive interventions, without the education, without the data to help us focus all of our health initiatives as well as our partnerships. I, for one, am really grateful public health is here, but even more grateful that I'm privileged to be a part of that work. Thank you.
Thank you, Dr. Newby. You do have a question, but before I call for the questions, I want to thank you for what you do with the health department. I don't think we always recognize how blessed we were to have you during COVID and where we would have been without you. Your background in epidemiology and our state, everyone has recognized how we came through it so much better. So we're very grateful for you and what you've done with the department. But we do have a question. Representative Sharper.
Thank you, Dr. Toomey, from the Lowndes County area, South Health District. And like I tell people all over, every citizen, you need the health department. When you're born, you need that birth certificate. When you die, you need that death certificate. So we actually, you know, everybody has to go through the health department one way or the other. But I was just wanted to mention this, and I don't know if this is the right time, but I just want to put it out there. But the SHAP program, the stroke and the stroke and heart attack prevention programs, I've seen those over the years. But I think that's a very good thing that we really need to look at, really getting more funding for, because I've seen it work in a lot of communities where you have people that have high blood pressure, diabetes, that doesn't have medical coverage at all. So that help a lot of people, because if you don't get the hypertension and diabetes things taken care of, now you're looking at renal failure. And so you see a lot of people that don't have these other programs, you know, where they go to the ER, get a, quick fix of trying to get them, stabilized. And the doctor always say, hey, go and see your personal physician. But your personal physician is back to the ER because you don't have any coverage.
Right.
But I think if we can look at those programs and see if we can do more, committee, the SHAP program is a very awesome program. And I think it has really helped a lot of people get the things they need and the services they need. So I want to go on record saying, whatever we can do, I think we can help a lot of citizens that doesn't have coverage. If you can elaborate if you want.
No, and I was going to say that was one of the programs that was here when I first got here years ago in the epidemiology. But I believe it was state funded because CDC was not at that point funding those kinds of services. So it was not a federal funded program. Dr. Groh was one of the biggest champions, and I think that it's something we spent a lot of time talking about yesterday at the health director meeting. So I really appreciate the value because we are a safety net in many places where there are, particularly in rural Georgia. You have a good health director now too, I believe.
Thank you.
He's in the audience.
Chairman Hatchett.
Dr. Toomey, I echo everything Chair Lady Taylor said about you. One thing that, and you don't have to answer this right now, but just what I'd like to get at as we progress in this committee is you mentioned in your presentation about services that you provide that people are having trouble with the transportation to get to you. And I really want to drill down possibly even more on the services that y'all provide. I know you talked about the data you gather and the other prevention things, but I think that each health department, each county may provide different services depending on the providers that you have. So I want to dig a little more there, and you don't have to answer anything right now. I just kind of a statement. So, but thank you.
And I believe Dr. Rustin, who's following me, is going to talk a little bit more about that. And part of it reflects the size of the county. We have 159 counties, as you are well aware, compared to some of the other states that surround us. And I think it's difficult just fiscally to be able to provide the same level of services as some of the larger health departments. But I think we can think about how even to regionalize some of this so you have access to all services. It's what we did with Nexplanon and the I've talked with some of you about that. It was again to me one of the greatest public health achievements we had in the last several years, because to get long-acting reversible contraception required kind of a periodic visit of a advanced practice nurse or transportation to one of the larger health departments. And we recognized you have to have that service in almost every county so that a woman can walk in and not wait till, whether her schedule coincides with the advanced practice nurse. And we were miraculously able to work out the ability to have our nurses under protocol insert these devices with FDA approval and special help from the company, and $11 million of support, and that I was able to get through DFACS. And with that kind of creative thinking, you can provide without kind of coming cup in hand as I do every session, to be able to expand services. But I think we'll talk about it, but I think there's certainly more to talk about, and particularly reflecting on the comment about the.
And that's kind of, I mean, exactly what you just said, that you were able to then provide it statewide. And I'm sure you have a list of other things that you might like to try to do that with. And since we do have a public health department, I believe in every county,
Exactly.
that helps with the access word that we hear so much about, that hopefully we can keep doing that. And I'm sure there's things out there that, it's the money, but if you don't ask, hopefully we can help in that direction some. So I look forward to hearing more about those
It's the money,
opportunities.
but it's the services.
Mm.
Good to keep that in mind. Yep.
The healthcare of the population.
Yes, it is. Thank you. One quick question. I know we've seen some success, and one of your programs you're very proud of is the visiting mothers, where you have someone going, you've got a
Visiting,
pilot
mhm.
project. Just a quick one up. Is it working well, and is it showing success?
Oh, it's working beautifully. And I think what has been, to me, such a stunning achievement is that we've been able to see those results so quickly within such a short period of time. Because as you recall, that was funded only a couple of years ago, and it started up as a pilot. And already in the pilot, it had shown improvements not only in maternal outcomes, but also babies that were identified postpartum when they went for the visit and had life-threatening conditions, and that those home visitors, sometimes community health workers, sometimes a nurse, were able to facilitate getting care. That, coupled with the expansion to the perinatal program and the telehealth that you have supported this last session, is going to make all the difference in the world, because it's going to allow that kind of access to high-risk moms, closer to home. It's going to address the transportation issue, but also that care issue that we've talked about. And again, I don't think we would have even known kind of some of these issues about transportation without that home visiting, giving us that kind of literally on the ground intelligence about what is happening and what the challenges are for these high-risk moms and babies.
That's one of the things as a legislature, we want to see where the state is putting their resources, that they're working and they're having success. So, Chairman Parrish?
Thank you. Timmy, I also want to thank you for the job that you've done over the years, and it's really made a difference, and you can be proud of that, and we're proud of it too. Things happen sometime, not necessarily the way we'd like for it to happen, and things that are going on now with maybe some uncertainty in funding and whether or not so many dollars that are really pass-through dollars, federal dollars to the health department. If you get it, that's great. If you don't get it, then sometimes that's a problem. But I guess I don't really want an answer, but what I wanted to do is sometimes it forces us, when you are going to have some changes, if some of these dollars in certain programs are reduced or eliminated, or there are changes, I'm hoping that you and your team are going to be looking at, what are we going to do if this continues? What are we going to do if that does not continue? And how will that affect the programs that we're doing? Do we need to look at the programs that we're doing and doing well to continue that and enlarge that to give that better coverage that's been talked about? Since you are in all 159 counties, that's a real asset to the state. But I hope that as we move along and we begin to get more clarity on whether or not there's going to be some dollars coming or not coming, and in the state, obviously we can help some, but I don't think we can make up all of those dollars unless Chairman Hatchett's got a sack full of money he hadn't been telling us about over there or something. But I think there's going to really be some challenges out there, and I know that y'all will be up to it. And I think one of the things that can help us make good decisions is if you and your department come back and say, we're doing this and it works well, we really can want to continue this and we need some help. This program isn't working as well as we thought, and if we have to eliminate something, this would be some things that we think we can do without. So please be thinking about that and being able to give us some ideas about how we might be able to help with that.
No, thank you. I couldn't agree.
Chairman Cooper?
Thank you very much. Well, Dr. Toomey, you know how I feel about you. And if you're tired of the Christmas story, you can just come up with the fact that we have developmental tasks through life. And one of the developmental tasks of being more mature is decide whether we're happy with our lives or not. Sit on the porch and think about it. And I think if you ever decide to sit on the porch and think about your life back, you will certainly be satisfied with what you have given. Because when you give, that's what's really important in this life. And you certainly have those accomplishments. So I don't think you'll have any problem being pleased with what's gone on in your life. The one thing I want to know is I've been studying, we now have, through Georgia, we've come up with our own way to get people covered. We have put about 700,000 people, we got them an insurance policy through the Affordable Care Act. Those were the people that were between 100%, 101% of poverty and 150. And then for the people that were up to 400% over that, there are about 800,000 that have policies also. Is there a way maybe in the future that public health would be able to fund a great deal of itself through those insurance policies? Has there ever been a state where public health has been able to use and charge policies? You know, they're now insured with their own insurance policies.
Well, I mean, that's the whole that's the whole framework of the health insurance continuation program, as you are well aware, because you know more about the HIV program than I do, Representative Cooper. But that's exactly what it does, because it provides that access to care. That's an interesting thought. I had never thought of that, but that's one of those things to explore. We can put that on the list of things that we're looking at.
Those that fell below now are on our pathway program. We have about 9,000 on that. You know, the estimates are that we are down to where we only have a couple 100,000 people uninsured. But the majority, over 1.5 million, have regular insurance policies through the Affordable Care Act. And it seems like we ought to be able to look for funding some way or other to capitalize on that for whatever public health could do.
And so much of that will depend on the federal level. And Dr. Burke, this is really his bailiwick, so I don't want to step on his toes, with total respect for him that I have.
Are there any other questions from the committee? We appreciate you and your presentation today. Thank you so much.
Thank you all for all your support. We really appreciate, all of us
Thank you.
collectively appreciate it.
We'll move forward now. Our next speaker will be Dr. Chris Rustin. Do you want the podium?
I'd like to stand at the podium.
There you go.
Right. So, Madam Chair, members of the committee, first, I want to thank you for letting me be here to present. As Dr. Toomey mentioned, I'm going to go into a little bit more detail on our structure, and some of the questions that I've asked, I think, may be answered based on some of the talking points that I'm going to present. And I want to thank Representative Sharper. He stole my line from birth to death. I was gonna use that. So you beat me to the punch, because many of our health departments offer vital record services. Am I transmitting to you all? Okay. So my name's Chris Rustin. I serve currently as the interim district health director in Fulton County, but I've served in a variety of positions in public health. Actually received my 25-year pin yesterday. So I've been working in Georgia public health straight out of undergrad. I grew up in Southeast Georgia. I grew up on a farm, so I'm very familiar with the rural parts of the state, and kind of fell into public health by accident. I really intended to do something different. At the time, I didn't know what I wanted to do, but ended up at a local health department, and really enjoyed the work and the mission, and have moved around. I've worked in a couple of public health districts in our state and at the state health department, and in a variety of positions. And as I mentioned earlier, currently serving as interim health director in Fulton. What we'll talk about today is our structure and how we are structured in public health. As Dr. Toomey had mentioned earlier, the history of public health goes back to the 1800s, but our structure is somewhat old, but it goes back really the modern structure we see today to around the late 50s and the 60s. One of the highlights that I'm going to present is the core public health services that are offered in every health department, and then compare and contrast that with what's offered in more larger urban health departments and what we see in our more smaller rural health departments. And then I'll follow that up with some of our capacity issues, and then how we are trying to address some of the access to healthcare issues with telemedicine, telehealth in our health departments. So this map has been shown many times. This is our structure, how we are laid out in public health. I know there's a lot of maps that across various agencies, but our map has us divided into 18 public health regions. Our mission, as discussed earlier, is relatively simple. Our mission is to prevent disease, injury, and disability, and we do this through our health departments in every county. I think that is what's unique about the public health system in Georgia, is that there is a health department in every county in Georgia. And I don't believe there's probably any other healthcare system that that has that capacity in every county. We also promote health and well-being. And lastly, prepare for and respond to disasters. This is sort of an area of public health that many may not be aware of, the preparation for disasters. And just to give you an example, there's a hurricane out in the Atlantic right now that thankfully looks like it'll make a turn and head out to the ocean. But all of our health departments in the Coastal Health District are preparing as if that hurricane may impact Georgia. And they do that through making sure that our nurses are prepared to staff shelters in the event those had to open, as well as we have individuals who are homebound that may need assistance evacuating the coast, and the health departments maintain a list of those individuals. And through the local EMA and the local partners in the counties will provide assistance to evacuate these individuals. So all of those activities happen year round, but become much more heightened during this time of year when there's a potential for hurricanes. All of these services that we mentioned earlier are provided through a little over 6,000 employees across the state, made up of state staff that work within public health districts, and obviously the staff in our local health departments where the service delivery is really happening. There's the State Office of Public Health, which is headquartered here in Atlanta. There's, again, the 18 public health districts. There's a Board of Health in every county that provides policy oversight for the health departments. And then obviously the goal is to provide all of these public health prevention services to the 11 million Georgians, but also the visitors that visit our state. And I'll talk a little bit more about how we impact visitors as well. Our core values revolve around 5 principles. Our people, we value our employees, but we also value our clients, our patients. And one push that we've really been asking our districts to do is to solicit feedback from our clients, our patients. We want to know how we're doing and can we improve, what we can do better. The value of excellence, again, accountability, ensuring that, and this is where the state health department and the state office working with the districts ensures that the money that's being provided is being spent on the services that you all want to see in every county health department. We can't provide public health without partnerships. I think that's a critical part of what we do at the state level, partnering with other agencies, but at the local level, partnering with other community services that are offered in the community to be able to have referral networks that are in place. Innovation, again, we are working very quickly, as fast as we can, to implement an electronic medical record system in every health department. That's not something that currently is in place. Every public health district, every county health department, in some regards, has a different electronic medical record system, which makes it very difficult to get data. Especially, and when we saw this during the pandemic, when we had requests for data, and in some cases, we had health departments that had to hand tally data. And so there's a delay in data of being able to capture that data and analyze it. And, we're real proud that we're moving to a centralized type of EMR where we'll be able to analyze data very rapidly and be able to provide information to you all, to policymakers and legislators when they request that. And then lastly, we want to ground our decisions on data and science. And good data means we make better decisions. And we do that by having systems in place to capture that data. And hopefully we use that to improve outcomes, as was mentioned earlier in our home visitation program. It took the data to drive those policies, to develop those programs that we're already starting to see benefits of. As mentioned earlier, Georgia's public health system is sort of a hybrid approach to public health where you've got state oversight, but you have county boards of health that are semi-autonomous, but it's through the district health director and through the leadership of the state where we work together to ensure these services are being offered. As I mentioned earlier, there's the 18 public health districts, and districts are comprised of a one county district like Fulton County to a 16 county district like our Waycross region of the state. Districts, the thought process at the time in the late 50s and 60s is that districts were combined based on population. And so Fulton County is a one county district because of the population. But when you look at like Waycross region of the state, they have 16 counties, but they still lack probably the population of half of Fulton. And so that's why you see sort of different sizes. It's really based on the population. And most of the metro counties are 1 to 2 to 3 counties, and then they start expanding outward into larger geographical areas throughout the state as you move into more rural Georgia. Each public health district is managed by a district health director. A district health director is appointed by the DPH commissioner, and upon when they're new and being appointed, they must be approved by a county board of health. And the way that works is the county boards of health will provide representation, and the candidate's presented, and they get to ask questions, and then they can vote on that candidate through a majority vote. And then once they're approved, then they are a state employee, and they report to DPH and report to the commissioner. Also, the district health director serves as the CEO of each board of health. So they're the CEO of the district, of each board of health within a district. And the district health director is sort of the linchpin of how we manage public health in Georgia. The Department of Public Health at the state works through the district health director, who has oversight of all the staff within the county health department. And those staff, the health director has his or her own staff to help manage. There's finance staff, there's clinical staff, there's an environmental health manager, and through these district employees, they're able to manage and oversee the county health department services that are being offered. But as I mentioned earlier, the various roles of public health at the state, DPH provides the general oversight and direction, the technical assistance that's needed with a program, especially if it's a grant-funded program. Obviously, the most important part is they allocate funding to the health departments and to the districts. They provide oversight of certain programs, And most of the pass-through funding, the federal funding, is awarded to DPH and then awarded as a subaward to the county health or to the districts for the county health department services. And so it's DPH that is ultimately responsible for those grant programs, which is why it's important for that accountability piece, that the funds are being spent on the services in the local health departments as it was designed for. As I mentioned earlier, there's 18 districts, and these districts provide the administrative infrastructure for the county health departments. It's really through economies of scale that they're able to provide those services. And for example, most health departments would not be able to afford an IT director for every health department. It's at the district level that you have an IT team that supports those county health departments. It's the same for human resources. It's the same for clinical oversight or environmental health oversight. Epidemiology is generally a district program that's providing that surveillance and assistance to those county health departments if there's an outbreak or if there's a need to follow up on some kind of disease. And then the county health departments is I'd like to say where the rubber meets the road. It's where the direct services are provided. That can range from STD screenings to HIV screenings to immunizations. In some of our counties, we have vital record services, and then our environmental health services through restaurant, hotel, public swimming pool, septic tank system inspections, also youth development programs, and then our community outreach, community health education is provided at that local health department level. And it varies, as mentioned earlier, by size of county on the degree of those services that are offered. So doing sort of a compare and contrast, there was a question earlier about what services are provided in urban counties versus more rural counties. And I'm going to talk more about the core services, but to set the stage, the two counties that I picked here to sort of compare services is Fulton County compared to McIntosh County. Obviously, Fulton County is, by population, is the largest county in the state, with over 1 million people in Fulton County. There's over 520,000 housing units, and the median household income is around $92,000 a year, around 13% poverty. And the citizens in Fulton, on average, about 94% have access to broadband internet, which is important. Having access to internet for our telehealth services, to be able to be connected with the world and services is important. And compare that to McIntosh County. And McIntosh could be an example of a lot of the rural counties in Southeast Georgia. I chose McIntosh because I visited there some. That population's around 12,000 people. There's about 6,800 housing units. The median household income's a little over 50,000. Poverty's around 22%, and it's much more broad and spread out across the county, where it's in pockets in Fulton County, where you have extremely wealthy areas of Fulton and areas that have very large pockets of poverty. And they only have about 83% broadband coverage in McIntosh County. This is important when you start comparing a larger county to a more rural county. When you start looking at capacity, services offered, how many days a week services are offered, that's where you start noticing the differences in those core services. As I mentioned earlier, in addition to health department being in every county, there's a county board of health. And we had, as mentioned earlier, there's a semi-autonomous structure in Georgia. The county boards of health are independent. They're statutorily in place. And within the statute, it delegates the membership of the Board of Health. There's 7 members in every Board of Health in a county. Some of those members are by position. So, for example, the superintendent of the largest school system has a seat on the Board of Health, or his or her delegate. The chairman of the governing authority, the county commission, has a seat, or his or her delegate, as well as the mayor of the largest city has a seat. And that makes up 3 seats, and then the other 4 seats are appointed by either the county commission or the mayor of the largest city. And those membership, it ranges from it is required to have a physician on the Board of Health, with the exception in smaller rural counties, if there's not a primary care or physician within the county, a nurse or a dentist could serve in that capacity. There's a community advocate on the Board of Health. and there's a position for an individual who just wants to support the community's needs. And that makes up the boards of health in every community. Their responsibilities are providing an assessment of the local public health needs. They can serve as a buffer for the health director if issues come up where they can talk to others in the community. Their role is to advocate for county public health programs. Their probably main regulatory role is approving the budget. The local board of health has to approve the budget of the health department annually, and that budget is then transmitted to the county governing authority. And then lastly, the responsibility of the board is to provide policy guidance to the district health director. So it's really a policy-making board. They're designed to provide guidance, to provide input. Citizens can reach out to the board, and the board can then bring that to the health director based on whatever those needs are. And that can help craft potential programs or expand programs within a community. As far as core staffing, every health department in Georgia is going to have a district health director. That's in place in every district. But there's going to be clinical staff in every health department. That is generally made up of registered nurses, LPNs, maybe medical assistants, in some cases advanced practice nurse practitioners. But as you move from urban counties where all of these positions are there every day into more rural counties, the advanced practice registered nurses may only visit that county 1 day a week or 2 days a week because they provide services across multiple counties within a health district. There's also an environmental health staff member in every health department. It can range from one environmental health staff member providing all services in a community to a team of 25 to 30 staff members or even more in some regards, depending on the size of the county and the number of facilities that are required to be regulated. And then there's a few administrative staff, of course, in every health department. Generally, we call them customer service reps. These are, in my mind, some of the most important staff members because it's the first person a client will visit or see when they come into a health department. So when you walk in to a health department and you see someone sitting at a window, that's generally our customer service staff. And they're the ones that are doing intake and working with you to decide where you need to go in the health department based on that need that day. These are the core public health services. These services are offered in every health department. It ranges from our immunization services for children and adults to women's health services through family planning, pregnancy testing, breastfeeding support. We have a breast and cervical cancer program, and women's, infant, and children. Our WIC program is offered in every county health department. We're very proud that we have moved to our eWIC program where now you receive WIC benefits on a debit card versus the old paper voucher system that was in place a few years ago. And in addition to that, nutritional services are offered through our nutritionist in the health departments. STD services are in every health department for testing and treatment. HIV services are provided, TB services. Our children's services range from our Children's First program, which is really the entry point for children to come into, and from there is determine what other services they may need, to our children's medical services, which provide special health care for children based off a health condition like cystic fibrosis or something of that nature where they may need specialized care, and we can help connect them to that care. Ears, eyes, dental screening, the EEDs as it's called, is offered in every health department. This is required to go into our school system. If you're a new student going into the school system, you have to have a certificate provided. And then lastly, environmental health services. And I want to just briefly mention that, when we say environmental health, the goal of environmental health is to protect the health of our citizens, our public, from the environment. And the environment's used very broadly. It's not the environment as in the woods or in out in the in the water. Environment is everywhere around us. It could be the air we breathe. It could be the water we drink, the food we eat. That is the environment we're referring to. It's not the EPA or our EPD. I wanted to make sure we understand that these individuals are trained to investigate and inspect facilities, and they're looking for hazards, whatever that environment is, that may impact the public. And so using the example of the cakes that were made that caused the large noro outbreak. It was, epidemiology identified what the issue was, and it was the environmental health team that went in and put the controls in place and figured out how it was actually happening. And so it's a symbiotic relationship of how EPI, our lab, our environmental health team works together. And they're responsible for inspecting our restaurants, our hotels, our public swimming pools, our body art facilities. Tattooing is a popular thing now, and there's sanitary issues that have to be ensured are met. They're responsible for septic tank inspections, especially in the more rural areas. You have to have a septic tank system for waste disposal, lead investigations. But one thing that I wanted to highlight that I think's probably not well known, but critically important, is rabies control is delegated to the Board of Health, to environmental health. And all animal bites in the state of Georgia are investigated by our environmental health team. Now, in our more urban areas, we work closely with animal control for those services. But in rural areas, there is no animal control. It's the environmental health staff that are investigating that animal bite to determine if the animal that bit the human or bit your pet has rabies or not, or if they're vaccinated for rabies. And it's a very important program, and it's a very busy program. There's a lot of animal bites in our state. And funding for our public health services, I'm just going to highlight this because our CFO at DPH is going to give a more detailed presentation on funding. But as you can see, there's a variety of funding that funds the health departments. The vast majority it is state funds that we receive and appropriated. Also, those federal funds that is mentioned earlier. We have other funds, which could be fees that are charged. Every health department is considered a safety net system with a sliding fee schedule. We don't turn people away for services. It's based off income in some places, and some individuals are seen without paying. And then local funds. This is contributions from the county governing authority. The county governing authority does provide, in most cases, the lodging, the buildings for the health departments, as well as funding for those programs. When you look at urban county health departments, these are your much more larger health departments, like Fulton County, like Metro DeKalb County, or even Savannah. There may be other services that are offered. For example, Chatham County has a WIC garden. It's a community garden where they year-round grow vegetables, and they provide those vegetables to the WIC clients as well as other clients in the health department year-round. That's something that you probably wouldn't always see in a smaller health department, but it's in a more larger setting. There's more expanded women's health services, meaning that they're offered daily versus in some cases 1 day a week. There's for HIV services, a lot of the urban county health departments are able to do walk-in testing services, treatment, and provide self-test kits. Colposcopy services are offered in some of our health departments through our women's health program. But one thing that I think is very important and is a very huge need in our state is oral health. Many of our health departments in more urban counties have a dental program where they're offering dental services in the health department. Some health departments focus on pediatric dental, like Chatham County, Savannah. Other health departments that have this service have adult and pediatric, and they're able to do x-rays, cleanings, fillings, and dental sealants for these children. We have car seat programs in many of our programs where funding comes from the Governor's Office of Highway Safety through DPH to health departments to provide car seats for families that need those. And they're trained on how to install them, so they are able to teach the family on how to safely install that car seat. And then one of our favorites is mosquito control. That's something that's offered in a few health departments. It's primarily in most counties where it's offered a function of county or city government, but in five health departments, it's part of health department services. Fulton County is one of those counties that have a contracted vendor that provides mosquito control services, compared to Richmond County, where it's a program within public health. It's actually public health staff that are hired that provide those mosquito control services. So these are kind of what you see in addition to core services in more larger urban settings where there's more funding available and much more population. When we look at access, again, comparing a urban county to a rural county, in Fulton County, for example, there's 8 facilities in Fulton County. As you imagine, there's a huge population, and these facilities are spread out across the county. There's mobile outreach teams available in Fulton, and services in all locations are offered 5 days a week. Compare that to McIntosh County, there's 1 health department location. And there, because of staffing being somewhat low, the public health district sends in staff to augment that health department to offer those additional services. For example, some of the women's health services are only offered 1 to 2 days a week in McIntosh County, where it's offered 5 days a week in Fulton County in a more urban setting. Public transportation is critical. Having access to transportation to get to our sites is critical. In a more urban setting, you're going to have many more options. Like in the metro region, you have MARTA, you have the MARTA Transit, MARTA Bus, you have the regional bus services, you have rideshare programs that are available. But when you start getting into more rural areas, there isn't those options. There's the regional transportation services that are available, but outside of that, there's not many other options. Partnerships in a more urban setting, there's going to be a lot more partners that are available, from community health clinics to FQHCs to other community-based organizations, where in a more rural setting, there may be limited partnerships. In McIntosh, there's 1 FQHC, and I believe only 1 primary care physician in that county. And then as far as hospitals go, I mean, the metro region has a large number of hospitals where individuals could go to. But when you get into more rural areas like McIntosh, there is no hospital. And so people have to go outside of the county to get more specialized care that may be needed at a hospital. When you look at capacity, I would say that our impacts are, while the size is different, we have similar impacts. And I believe on our panel, we're going to talk more about that in detail, but we all face recruitment retention challenges, from nurses to nutritionists to our environmental health team. There, again, I mentioned earlier, there's clinical capacity impacts in smaller counties. The types of services offered may be limited, or it may be limited to certain days of the week versus every day of the week. And then for our more rural counties, response time for environmental help is very important. When someone is building a home and they've taken out a construction loan for their property, they're on the clock for paying for that construction loan. And so our ability to turn over a septic permit so they can actually start building that home could be impacted by staffing, for example, in a more rural county where there may be 1 environmental health specialist versus a larger county. And this just puts it a little bit more in perspective. Fulton County has around 400 staff, and they're able to provide services 5 days a week in all of the locations. And compare that to a more rural county like McIntosh, they have 5 staff in the health department. And that's, population-wise, probably may be appropriate. But if you look at it from the perspective of, they have 2 RNs. If 1 RN calls in sick, half their workforce is now gone. If both RNs call in sick, they're going to probably cancel some services that day, or the district's going to have to augment and send staff in from another health department to provide those services. So those are the types of impacts you start seeing when you start contrasting a more urban county to a more rural county, is the staffing component of that. How do we handle access? One of the things we're very proud of at DPH is our telemedicine access program. This is something that is available. The telemedicine capability and equipment isn't available in all of our health departments. We've been working hard to expand this, and I'll give you a few examples. Our children and youth with special needs clinics, these are available in 120 counties across 10 rural health districts. And you can see the various we call them lead counties. These are the headquarters of the district. And you can see the county numbers there that are offering these services. And these specialty clinics, through our Children's Medical Service Program, provide genetics, neurology, pulmonology, endocrinology, and sickle cell services. And we are partnered providing telemedicine services with Children's Healthcare of Atlanta, Augusta University, as well as various pediatric genetics programs that are available through our university systems, our university medical care systems. Another service is HIV telemedicine. This is something that is offered extensively in our Waycross region of the state, as well as our Dalton region of the state, which is kind of straight up north. These telemedicine services provide consultations for also for our complex TB cases. There's pediatric audiology that's available in our Valdosta region in collaboration with CHOA, Children's Healthcare of Atlanta. And as I mentioned earlier, all of our health departments have this capability, and it's our goal to work to expand these services where those needs are, to ensure that we are providing more access to these more specialty types of services that are needed, especially in rural areas. Teledentistry is offered in some of our regions of the state. This is where we have dental hygienists that are providing dental screenings, cleanings, education. They're doing x-rays and sealants under the remote supervision of a dentist. And the dentist is able to remote in and supervise these services and read x-rays and work on a treatment plan with that child, that parent, and that dental hygienist on site. In District 9-2, which is our Waycross region, this is offered in Brantley, Charlton, and Clinch counties. They partner with 2 local dentists and a pediatric dentist at the Dental College of Georgia. And then in Chatham County in District 9-1, the Coastal Health District, there's a health department, a dental clinic within the health department in Chatham, and that has now been expanded to providing teledentistry services in the school system. And this program is now being expanded to Glenn County on the Brunswick end of the public health district. PrEP services, this is medicine that individuals can take who are at risk of getting HIV to prevent the infection. We can offer telehealth for PrEP. Usually an in-person visit is required initially to establish a baseline and to gather labs, but from that point forward, telehealth can be used to continue this service for that particular patient. And this is currently being offered in our Fulton County Health Department, and it's something that potentially could be expanded across the region, across the state. And then I want to sum up kind of our structure. As Dr. Toomey had mentioned, we have a Georgia Public Health Laboratory, and I would be remiss not to highlight these services that are offered. Our headquarters for the laboratory is in Decatur, but we also have a smaller facility in South Georgia in Waycross. There's 151 clinical and support staff at our Georgia Public Health Lab, and there's currently 115 assays that can be ordered. These tests are performed for county health departments, they're performed for hospitals, and they are able to provide rapid results to our facilities so we can make decisions. Our newborn screening program, which is probably our most important program, I would say, at our public health laboratory, provides a screening for over 35 disorders for our 126 or 20,000 plus newborns that are born each year. And just to put this in perspective, in our fiscal year 2024, there was over almost 360,000 specimens that were processed, over 8 million tests were provided, and over 280,000 quality control procedures done on those tests to ensure accuracy. And these tests, range from our disease prevention and surveillance, newborn screening, food safety testing, STD testing, to various microbiology testing that's available. There's the emergency response for bioterrorism agents, and a variety of other types of tests that are available at the lab. And so we're real proud of our laboratory and the ability to be able to respond quickly because of the services that they provide. And in summation, that's kind of our structure in a very short period of time, but I am happy to take questions.
Chairman Hatchett?
Chair, Lady Taylor, I have several. Is that okay? Chris, you covered a lot of stuff. Thank you for what you do. Back to the EMR that you mentioned early on. What's the timeline for completion and what's the name of it?
Sure. The name of it is Patagonia. That's the brand or the vendor that was selected. And it went through a formal RFP process, and that was ultimately the vendor selected. The timeline's around 24 months. There's currently 4 from about right now forward, so around 2 years. Our health departments currently are serviced by 4 different EMR vendors. So 15 health departments are serviced by, or districts are serviced by one vendor. But within the districts, it's customized, so it's not even the same. Even though it's the same vendor, it's the same. It's not. It's a different type of system, basically, on how it's customized. Our goal is to roll this out in waves. We're going to do a pilot. We're doing a rural pilot in your region, in Dublin region, and we're doing a pilot in the Augusta region. And the purpose of the pilot is to work out the kinks, to make sure that it's what's needed for public health. And then we will start rolling it out in waves, doing 2 districts at a time. Simultaneously, the existing EMRs will still be functioning. There won't be a hard cutover until the system is stable and the health department staff feel comfortable using the system, but it's about a 2-year timeline for it to be successful.
Okay, in Fulton County specifically, it says that you do have physicians that actually work for Fulton County Health Department. How many do you have? Are they full-time? What is what they do?
So we currently have around, I believe, 3 to 4 full-time physicians that are on staff. But we contract with a variety of physicians that provide specialty services like TB consultation, HIV consultation. And so we have a chief medical officer who provides oversight to the clinical staff. But it's around 3 to 4 physicians, I believe.
So none of them are offering like primary care.
There's limited primary care that's offered. It's our primary mission is preventive care, and so there's very limited primary care that's offered in our clinics.
Are you aware of any other county health department that offers primary care?
The only
Unlike what y'all do.
Sure,
Okay.
sure. I'm not aware of any health departments that are offering adult primary care. There is programs for hypertension that's being offered, but what I have seen is in a few health departments, there's very limited pediatric primary care offered, and it really depends on the expertise of the nurse practitioners on site.
Labs so this help. I'm not a professional, so do you transport the specimens to the labs, or is there stuff that's done in the office that then is downloaded to how's that? I'm just curious how that works. That's another transportation thing.
No, it's an important question because we're currently studying that right now. A few of our health departments have in-house labs that offer basic services, but the vast majority of the services are offered at the Georgia Public Health Lab. And the way that works is the laboratory has a courier service, and the courier service goes to the different health departments to pick up those specimens, and then they bring them to the lab that's either closest to them or based on what service it is. Some services are only offered in Decatur versus Waycross.
Okay. Thank you. That's all.
Welcome.
Thank you, Chairman.
Representative Dexter. I'm sorry, Sharper.
Thank you, Sharon. Thank you, Dr. Rustin. 2 quick questions here. I noticed, they go to the hotels. A lot of times when the health department goes to the hotel, is it based on somebody complained about something, or they're on a regular schedule? How does that work normally?
Sure. So the program, the facilities that are regulated by environmental health is mandated in statute and rules a minimum number of inspections that are done a year. A hotel generally is inspected a minimum of twice a year, usually in the spring and in the fall. But if a complaint is received from the public or from someone that's staying there, that generates like a one-off inspection where we'll go in and try to address that particular complaint. And if it's a minor complaint and that issue can be addressed, it's treated as just that, a complaint that's being addressed. However, based on what the environmental health specialist sees, that may generate a full inspection of the facility. And so there is a schedule of inspections, but they're unannounced inspections. We don't tell the facility owner when we're coming.
Okay, and they'll get the pools, and then if there is food services there and possibly room.
That's right.
A random room or something.
Well, generally we try to do 10% of the rooms. And as you can imagine, in a 50-room hotel, that's 5 to 6 rooms. But then contrast that to Metro Atlanta that has a 50-story building, could be 200 or 300 rooms, depending on the size of the hotel. But we try to do a sort of a representative sample of the rooms that are available. And in some regards, we have to go in rooms that are occupied, because these are hotels. Part of their permitting is that we have to have access to do the inspection, to be able to make sure that what's in the rooms isn't a hazard to the hotel.
Okay, and second little question here. We talk about the federal disengagement of some funds. Is the state in connection with the boards and everybody talking with the county commissioners and others about what's going on that we may have to step in if the federal
Yeah.
goes down? And you got some places here where there's not a lot of state, but there's a lot of federal. And so, and no county or little county. And also, are we looking at trying to figure out a creative way to get some private funds, donations, or just working with organizations to kind of help, with the decrease in the federal funds?
So the district health director is, as I mentioned earlier, the CEO of every board of health within a district. And the district health director reports to the commissioner. And so the information that flows from DPH is through the district health director to update those boards of health. And the boards of health has membership of the county commission as well as the city council. And so that's how the information flows to provide those updates. And so every quarter, the boards of health meet, and those types of updates are generally provided by the district health director. So they're fully informed. And again, in most counties, the county commission chair sits on the board and is able to take then that information back to the full board of commissioners to see if it's something that they may want to fund independently, if funding is being decreased. As far as the private sort of public partnerships, those are happening around the state. Districts do partner with private organizations, with CBOs to offer services or expand services. And depending on what the funding, landscape looks like, that may be something that we have to look at even more closely.
Okay, thank you so much. Thank you.
Representative Osteen, you have a question?
Thank you, Chair Cooper. I appreciate this very informative pamphlet and presentation today. I'm a former school nurse, one of the many things that I've done in my career. And I was floored last week to realize when I saw the presentation of the urban versus rural, the services that are offered, in particular, two things for children. Since I am a former school nurse, the sick visits that are offered in urban and not offered in rural. But even more important than that, to me, well, not maybe more important, but our dental issues that children see. A lot of times, if you just give it some time, it'll go away, right? Whether it's a virus or whatever, a lot of times it'll go away, whether or not you treat it. That's not an absolute, but now dental issues are a little different. And I used to see a lot of cavities and abscess, and it's expensive to go to the dentist. And so when I noticed this last week, and then I see today that in District 9-2, which is where I am, the Southeast District, I'm in Coffee. So it would take an hour and a half-ish to get to Brantley or Charlton. And then Clinch would be about a 40-minute drive, maybe a little bit longer than that, 45-minute drive. So I'm curious as to why that's not offered more in every county, at least teledentistry, if you can't have a dentist there, just for children that can't afford to go, whose parents can't afford to take them to the dentist.
Sure. I think it has to do with capacity. There has to be a supervising dentist that's available, that's willing to do this. And that's something that, there's just like some medical professions, there's also shortages of dentists, but finding dentists that's willing to serve as that supervisory dentist. Not every district has a dentist on staff. You're probably more larger urban areas are going to have dentists on staff, more rural areas, they're contracting with dentists. You're exactly right. To put things in perspective, in Savannah, when they did the first teledentistry program at the school, the very first assessment, over 70% of the kids that were seen had significant dental issues. And those kids either had to be seen in the clinic in the health department, or they had to be referred out to other dentists. I'll take that back as something to look into.
Because
with
if you
the- with
can't,
the
if you
team.
hurt, you can't learn.
Yes, yes.
And then you go home and you can't sleep because it hurts. You can't eat because it hurts. And it's just a progressive
Mm.
thing and still until the tooth
Mm.
comes out. And then a lot of times that tooth is already damaged too. So anyway, I noticed that and I would love for you to look at that.
We'll look into that and get back to you
And
all
we-
on that.
Chairman Cooper?
Thank you very much for the presentation. I'm sitting down here trying to decide how I can be nice. And I don't mean to not be that way to you, of course. It's just I have real concerns about how the system works. And okay, so it's like on the dental issue, because I was going to ask that question too, because two things that send children's to the hospital are asthma and dental issues. Is one of the problems that you're having still the problem with the dental board and the dental association that say that there has to be a dentist right there in the building or right there by telemedicine? Did we ever get that? And they did not trust their dental hygienist that had, that they approved, that had 3 to 5 years of experience and just were going to clean teeth and get the stuff back to them to be able to work independently in these schools. Is there still a problem that we are having that's causing us not to be able to get more dental care to our kids at the school level?
So I can only speak to the public health side. There's a carve out for public health, and Megan Andrews is here and can provide more details on that. But there is a carve out for public health to be able to provide these services through a dental hygienist. And it hasn't been an issue, at least on the public health side, as far as dentists providing sort of remote supervision. But
Well, like it used to be, you couldn't go and see a hygienist in a public health clinic unless the dentist was there. And like you say, sometimes they're only there once a week or something.
Yeah, I think you're referring to the requirement that the supervising dentist be within 50 miles
Is,
of where the telemedicine service is being provided.
is that still
Yes.
a problem?
It's still in statute,
It's
yes.
still in statute.
So there
so
does
that-
have, through the teledentistry program, there still does have to be a supervising dentist within that 50-mile distance.
So in other words, well, why? It's because the dental association and the dental board wants it to tell you, okay, and they fought it. So in other words, if there's a dentist up here in Metro Atlanta that's willing to help us at McIntosh County or somewhere like that and supervised by telemedicine, they can't because they're 350, 400 miles away.
Yeah, and the reason for that is they want the supervising dentist or the referring dentist to be in a drivable distance to the visit. So if there's an issue with the child and they need to go see an actual dentist, they want it to be a dentist that's close by. That's the reasoning behind that.
You can't, yeah, right.
Yes.
Okay.
So yes, the answer is no.
Okay,
yeah.
thank you. We still have a barrier to care. Okay,
Mhm.
thank you.
You're welcome.
I mean, and I just have to say it. I was told over and over again, if dental hygienist cleaned a child's teeth, first of all, they started without the dentist in at first, that they could kill them. I don't know, and everybody I've said, when you go to the dentist, and we all go to the dentist, we don't see the dentist first before the hygienist cleans our teeth. They come in afterwards. So we've had a real problem in that area. And I have a special problems when it interferes with our children, when there is things available that they can do to try to help them. And the representative is right. If your mouth and you're hurting, you can't learn. Okay, I have the other questions that I have. Is there by statute a percentage of money that each county must contribute to their budget?
So, and I believe our CFO is going to talk about this in more detail. There is a match requirement, a formula on how counties contribute a certain percentage, and it's based on a variety of factors, including population, poverty factors, and those types of things.
Oh, okay, because I think and that we're saying that we work together and all. Well, some counties work better with with what the state would like to see than other counties do. It's just the way it is. And I was really shocked because I think, like a lot of legislators, I thought the counties put in a whole bunch of money toward the care. And I saw the list. The one that stands out to me is Gwinnett. When we had some problems with Gwinnett, and it held truth for all the counties I saw listed, which we didn't put out at the time. The county put in, Gwinnett County, as big as it is and as wealthy as it is, put in something like 2.5 million. And the state put in something like 22.5 million. And yet the county was telling the state what they would not do to try to treat our citizens. It seems like it's the horse that's, it does leave the cart, but it seems like they've got it in reverse and they're making the decision of where the cart's going. And I think that may be a problem, and the counties get to decide also what's offered. And I guess the other thing I had, when we get this electronic system, it has been in the past, and this is before Dr. Toomey came, I think, and I want an update, is that people would go in and get blood work. And in certain counties, in fact, a lot of them, they didn't keep a chart on that patient or anything. They just put the results in a stack. And there was no way to tell how many people that district was seeing. I mean, that county, that health department was seeing. It was just, okay, we're going to tell you this number. We saw this many patients about this, and we saw this many patients. It's not that I distrust all the counties, but having seen it over the last 30 years of working, I think it's trust but verify. And will the electronic records help us know what's really going on? We'll be able to tell if they really are seeing patients. I mean, when I did public health as a nurse, and when I was a student nurse, when I finished, I said I would never, ever do anything in public health again. I did it in the Smoky Mountains and with patients. And you would have a very sick child and you would get an antibiotic and you would walk a mile to get it to their house off the route. And then you go back and the kid was sicker. And because somebody, Aunt so-and-so, told them some home remedy that would do it. And I really came out and said, no more public health, no more. And it's amazing. Don't ever say ever, never, this kind of thing. But there's so much, like on maternal child health, and just being, you don't have to be a nurse practitioner. You can be an LPN, because now there are things and equipment that can give a doctor at a nearby hospital that delivers babies, or that can tell you what's going on with that baby and if it needs to be seen. So we really could have, and especially maternal health, which really is an emphasis of mine, we could do so much more if nurses would practice. And I guess that's what I'm getting. And I will quit on my thing, but I would like to know, out of all these tests you did, are you getting paid better for it? Because it used to be they would send out a bill from the labs, and they would see one bill and didn't get paid, and they would send a second bill, and then they never sent any more bills.
Yeah.
And we would be owed hundreds of thousands of dollars in back money. Are they paying up as we try to get more money? I guess I just needed to get those questions asked as we go forth, and the federal government looks like cut programs, and we're going to be expected to do more. I think we just have to tighten up on everything. And if we have a source like doing all these lab tests, which are very expensive and which most labs wouldn't do, we need to get paid from whatever source we can get paid from. And I'll get off my high horse, and thank you very much. And thank you, Dr. Toomey, we're running a whole different ballpark. I don't think we have lost a highly equipped lab bus and everything that used to go around, which was lost. Nobody knows what happened to it, and it was not even insured, so we could recover on it. Thank you.
Thank you. We appreciate that. Chairman Parrish?
Thank you, ma'am. Dr. Rushing, thank you. That was a good report with a lot of good information, and I certainly have a better understanding about public health and what we're doing. But my question is this, and you pointed out very vividly the difference in the counties in the state, like the Fultons and the Gwinnett's and the McIntoshes. It's night and day. There's a difference, and it's certainly not a one size fits all. And my question is this, in large areas like down where I live, they may only have that nurse practitioner come into that office, as you point out, like one day a week maybe, or something like that. Have we given any thought to working with community health centers? They're in like 139 counties now, I believe. And they're there basically 5 days a week or 7 days a week, whatever they are. And if you get that person, the nurse practitioner's in the office on Monday, but a sick person comes in on Tuesday, you know, there we are. Are we doing anything to try to work cooperatively with the clinics to refer patients to them and let especially in the rural areas, let the health department do the things that you do very well, like the environmental services and things where you have to inspect the restaurants and make sure the septic systems are working, and put more emphasis on those projects to make sure you have the resources to do it in a timely fashion, but maybe cooperate with the community health centers or something so they could do what they do in a timely fashion and treat that kid 5 days a week instead of just 1 day a week.
No, that's an excellent point. And it became, I think, even more critically important during the COVID response. We started working with the community health centers, the FQHCs around the state, to identify where they were located. And I know many of our health departments have referral mechanisms in place with those FQHCs, especially for primary care services that aren't offered in health departments. Or if a patient is seen with, uncontrolled diabetes, they could be referred to one of these community health centers. So it is something that is happening. We can certainly work on improving that type of referral network, but it is happening in many of our locations around the state.
Well, I'm glad to hear you say that. And I think that's an area where we can allow the health department to do what you do very well and should be doing and give you more resources to do it, but let somebody else do something that they can do well as well. And sort of tying into that, you mentioned about the electronic records, that these will, where all the health departments will be on a common platform. Is
Yes,
that
sir.
right?
Yes, sir.
So if somebody goes to the health department in Fulton County, but then they move to McIntosh, they'd have those same things.
The Macintosh would have access to those
Right.
records no matter what.
What about like with a community health center?
Mhm.
Would they be able to communicate with your medical records? If this child goes to them, but they get referred over there, can they get that background of what immunizations they may have had or blood pressures or whatever like that?
It would require a connection, some type of interface. Could it be done? Yes. I think the goal right now is because we don't have this in the health departments, is to get a system in place that's consistent across the state. And then once we stabilize it, then we can start looking at whether those types of interfaces and connections are needed. But so the answer is yes, it could happen.
Yeah. Well, thank you. Like I say, for a very good report that has a lot of good information and helps me understand it a whole lot. And I hope we'll work toward trying to do the things that you do well and see that you have the resources to do it. And then let's look how we can do some other things differently and do them better. Thank you.
Thank you. And I'm sorry, but I have some questions for you too. I'm going back to the beginning of the true structure. When there's a selection of a director at a district, it has to be approved by the local. Has that been a problem?
It has in the past because it used to require concurrence amongst all Board of Health members. It wasn't by majority, but the legislators, you all have changed that law that now allows a majority vote, which makes it easier to present a candidate, and it prevents maybe one holdout out of 16 counties that could sabotage an entire selection process.
that was a concern that I had. And you also talk about the members on a local board. There's a statute that there's 7. It doesn't matter if it's a Fulton County or a McIntyre County. There's only 7 on the board.
That is correct.
Okay. And does the district director have to follow the guidance of the department? That is a concern. Who's in charge?
Yes, the district health director is a state employee. They report to the commissioner.
Okay.
And so they are required to follow the guidance of DPH.
That leads to my next question, which is the staffing. I know you have the core staffing, and then you have the district director, but the employees, are they county employees or are they state employees? And what is the?
So as I mentioned earlier, we're kind of a hybrid system.
Mhm.
So the county board of health staff members are technically county board of health employees. They're not employees of the county commissioner. They're county board of health employees. An example of a comparison is like the Board of Education. Teachers are employees of the Board of Education. Health department staff are employees of the Board of Health. But the difference is they receive the exact same benefits of a state employee, the retirement, the health benefits, all of the benefits of a state employee are provided to a county board of health staffer. So on paper, they look identical, but they are considered county board of health staff. They're not state employees.
Okay, so their paycheck quote comes from the county.
That's from the county board
Okay,
of health.
but their
Yes.
benefits and seniority and things like that accrue as a state employee.
That is correct.
Okay, and if you talked about treatment, and that's kind of where Chairman Parrish was. There's limited amounts of treatment that you can actually do. Do you prescribe medications? Can you give someone a prescription?
Yeah, our advanced practice registered nurses under a delegating physician can provide certain, they have certain prescriptive authority for like antibiotics, things of that sort. Yes, ma'am.
Okay. And finally, it had to do with the rabies and the animal control. I'm in a rural area and we often have trouble. Do you keep records of the dogs or the animals when it's positive rabies?
Mhm.
But what about those that actually have their animals vaccinated?
Mhm.
Is that registered with you?
No, not necessarily. They are by statute required to, all cats, dogs, and ferrets are
Yes.
required to be vaccinated for rabies. Those records are typically, and it really depends on where they're maintained. In some rural counties, the records of their vaccination are maintained by their vet. In more urban counties, like Savannah, for example, you're required to register that with the animal control program. So there is a registration. However, all animal bites are tracked through our electronic system called SINS, we have a module that tracks the victim that's been bitten, and the victim could be a domestic animal. Your dog gets into a altercation with a raccoon, for example. We're tracking all of that information, and if we know when we do the investigation, if your animal, your dog, your cat is vaccinated for rabies, then we do monitor the animal for a certain period of days, but it's what protects them from getting rabies and protects them from transmitting it. The problem comes into is if it's a wild animal and the wild animal attacks a human or attacks a dog or a cat, and that dog or cat's not vaccinated for rabies, there is a strong chance of the animal contracting rabies. And so they usually have to be euthanized or quarantined for a very long period of time for monitoring. And then on the human side, if we aren't able to test the wild animal, then we recommend rabies post-exposure treatment for being exposed.
Thank you very much. This has been a very informative presentation, and I think you've given us a lot to think about and a lot to look at. And I do appreciate it. We really laid you down with some questions there, but thank you for handling it so well. We appreciate
Thank you.
that.
Thank you.
We are going to take a break. It's nearly the noon hour, so we are going to take a lunch break. We will be back at 1:00. Oh, 12, I'm sorry, 12:15. We're not going to get as long as you thought to eat. Thank you.
I mean, like, it's coming out very good, so like, there's.
No,
Not so much.
Their state.
Yeah.
Something's coming out, right?
Thank you. We are back in business here. Our next presenter will be William Bell, and you will be at the podium. Please begin your presentation.
Well, good afternoon, everyone. My name is Will Bell, and I'm the Chief Financial Officer for the Georgia Department of Public Health. And so this afternoon, I'll provide an overview of DPH's budget with an emphasis on how DPH provides funding to county health departments. As a starting point for any discussion regarding DPH's budget, I would like to begin with a pie chart of our budget by funding source. So in total, DPH's appropriation across all funding sources for FY26 equals $922.5 million. DPH is a predominantly federally funded agency, with around half of our FY26 budget comprised of federal funding sources. Our federal funds for FY26 are budgeted at around $464.8 million, and around $250 million of our federal funds are related to WIC, our Women, Infants, and Children program. In fact, WIC represents over 50% of our base federal funds and is the predominant cost driver of our federal funds each year. And as you'll recall, WIC is a nutrition program that provides direct food benefits, nutrition education, breastfeeding support, and referrals to other health and social services to over 220,000 Georgians. Some additional federal funds within DPH's budget include $65.1 million for our Ryan White Part B program, which provides treatment for individuals with HIV/AIDS. We also have $20.3 million in the Temporary Assistance for Needy Families Block Grant, or TANF. You may know that Georgia's Department of Human Services, one of our sister agencies, is awarded TANF, and we are a grantee of their TANF funds, and we utilize TANF to provide women's health services as well as adolescent and youth health development services. We have $17.3 million budgeted for our Maternal and Child Health Block Grant. This funding provides programs and services that support women, infants, and children, including children with disabilities. We also have $5.3 million for our Preventive Health and Health Services Block Grant. This is a cross-cutting grant that provides funds to programs ranging from our environmental health program to another one of our sister agencies, the Criminal Justice Coordinating Council for Sexual Assault Centers. And please note that our budget, as depicted on this pie chart, does not include any COVID-19 era federal funding sources.
As a reminder, the most significant impact to DPH's federal funds occurred in March 2025, when 11 federal COVID-19 funding sources were terminated. The amount of funding awarded to DPH was $877.6 million. However, of that amount, around $554 million was spent, and the remaining $323.7 million was terminated. However, at this time, aside from COVID-19 related funding sources, only minor federal grants have been impacted with the federal uncertainty. I just wanted to acknowledge the unique uncertainty, of course, in our federal funding situation, that we are working through updated information on a weekly, if not daily basis as it relates to our federal funds. To our state general funds, which is depicted here in this blue share of the pie chart. Our state general funds for FY26 are budgeted at around $402.7 million. And around half of our state appropriation is budgeted for general grant and aid to county health departments. And of course, I'll be talking a lot more about that over the next several slides. Additional cost drivers for DPH's state funds are personal services expenses such as salaries and fringe, as well as contracts with partner organizations, and many of those through legislative initiatives that I think a lot of you are familiar with. DPH has other funds budgeted at $22.6 million. Some examples of other funds within our budget are $12.6 million in restricted funds for immunizations for children enrolled in the Department of Community Health's Peach Care for Kids program. We have $1.5 million in fireworks trust funds received from the Department of Revenue and utilized exclusively by one of our attached agencies, the Georgia Trauma Care Network Commission for Trauma Care. We have trauma care trust funds at $16.3 million at around 2% of our overall appropriation. And this funding is, of course, utilized exclusively by the Trauma Care Commission for trauma center readiness and uncompensated care, commission operations, and trauma system development. 2% of our budget is related to tobacco funds at around $13.9 million. The dominant cost driver within our tobacco funds is the Cancer State Aid Program. This is a program that provides access to services for eligible patients diagnosed with cancer or conditions highly suspicious of cancer. Tobacco funds also provide funding to the regional cancer coalitions and the Georgia Center for Oncology Research and Education, or Georgia Core. And lastly, we have brain and spinal injury trust funds at around $2 million, and these funds are utilized exclusively by the Brain and Spinal Injury Trust Fund Commission and support distributions from the trust fund to individuals who have experienced a traumatic brain or spinal cord injury, They also support the administration and operations of the Brain and Spinal Injury Trust Fund Commission, and they also maintain a central registry of all individuals who have a traumatic brain or spinal cord injury. So in contrast to our pie chart of DPH's appropriation, I also wanted to provide a summary of funding sources utilized by county health departments, just again as a comparison of the pie chart we walked through for DPH. So federal funds. County health departments receive federal funds, and those are allocated from DPH to counties mainly through programmatic grant and aid. And I'll come back in a little bit to explain what programmatic grant and aid is. Counties may also independently apply for and receive federal grants without those funds passing through DPH. For example, some county health departments receive Ryan White Part A funds independent of DPH and directly from the federal government. State funds, of course, our county health departments receive state dollars. State funds are allocated to county health departments by DPH as both general and programmatic grant and aid. Before I walk through these final three sources of funding for county health departments, I did just want to point out that these sources of funding are not reflected in DPH's budget or financials, that these are maintained at the county level. But I wanted to identify them briefly because you'll hear references to these sources both in my presentation and also in the roundtable discussion coming up here in a minute. Fees and insurance. County health departments generate funding through fees and payments from private and public insurance providers. County health departments charge user fees for services such as immunizations, women's health services, and restaurant inspections. In most cases, fees generated by grant-funded programs must be used to supplement the budget for that particular program. Local funds. We've had some discussion this morning on local funds. All Georgia counties are required to contribute to their local county health department based on the master agreement between DPH and the health department. The local match, as we call it, has not changed in 50 years. And of course, I'll provide a little bit more information on this shortly. And lastly, county health departments also have other funds, which are donations, contracts, and grants from private organizations. Before getting into grant and aid, I wanted to provide some information on head counts, both total for county health departments and for the state. I think while Dr. Rustin mentioned this morning, the staff at our county health departments are truly county employees. They're not state employees. The employees for DPH are state employees. Our total head count for county health departments from FY25 was around 4,245 staff. And our head count at DPH for FY25 was 1,079 staff. State funding sources pay for around 49% of DPH's payroll, and federal funds pay for around 50% of DPH's payroll. I want to provide a little bit of a breakout of that figure I showed on the prior slide, the 4,200 figure. As I think we know, based on Chris's presentation, county health departments comprise public health districts, and here's a snapshot of head counts at our public health districts from FY25. And so as you can see here, our head counts range from 98 staff in our Clayton County Health District to 303 staff in our Fulton County Health District, with median head count around 239 staff. It's okay. So we'll go to our next section, which is an overview of grant and aid. So what is grant and aid? County health departments expended around $389 million in grant and aid funds during FY25. Grant and aid consists of state and federal funds provided initially to the Department of Public Health, or DPH. These funds are then allocated from DPH to county health departments and public health districts. And grant and aid comes in two forms, general and programmatic. Prior to walking through each type of grant and aid, I wanted to provide a breakdown of total grant and aid expenditures by public health district from FY25. So in FY25, grant and aid expenditures range from $10 million in our Clayton County Health District to $28 million in the Gwinnett Newton Rockdale Health District. And median expenses are around $22 million. And as we begin to transition to the two types of grant and aid again, I wanted to show a comparison of how the two different types of grant and aid are expended at each health district. General grant and aid is in the blue shade, and programmatic grant and aid is in the green shade. And on average, general grant and aid comprises around 48% of total grant and aid expenditures, while programmatic grant and aid comprises the remaining 52% of grant and aid expenditures for each health district. So general grant and aid. General grant and aid expenditures from FY25 equaled $187.8 million for all health districts. General grant and aid funds are state funds that are intended to support the county's public health infrastructure. And while these funds are not tied to a specific program, they must be spent in compliance with the master agreement between DPH and the County Board of Health. DPH enters into an annual master agreement, which is essentially a contract, with counties to establish funding and services. The agreement requires that a county's public health services include women's health, environmental health, epidemiology, health promotion and disease prevention, infectious disease control, and emergency preparedness. The master agreement also requires Georgia counties to contribute to their local county health department. So as I mentioned earlier, the local match requirement has not changed since 1972 when it was adopted by the Department of Human Resources. The match requirement is relatively low, and most counties today provide more than the required amount. In 2024, which is the most recent data available that I have, the local match requirement for all counties was $12.2 million. However, total county funding was around $48.5 million, meaning that counties provided a total of $36.2 million above and beyond the required local match amount. The match amount was based on tax digest and population data from the county and state back in 1972, or it could have been earlier from what I've read. And I did want to point out that in 2024, in FY 2024, we had 3 counties that did not meet the match requirement: Walker, Troup, and Candler counties. So general grant and aid funds are allocated to counties through a formula last updated in 2011 that considers the following elements: a county share of the state's population or population share, a county share of the state's population living below the federal poverty level or poverty share, and a ratio of individuals living below the federal poverty level in a county relative to the state's federal poverty level or poverty rate. These figures are then weighted by the percentages within the formula, and those are the 40-40-20 figures you see within the formula. Formula allocations are updated each year based on the Census Bureau's most up-to-date population and poverty estimates. Additional adjustments related to statewide changes, such as the state health benefit plan, employees' retirement system, risk insurance premiums, and cost of living adjustments and merit-based pay increases are also allocated to each county via general grant and aid. So on the next slide, I have general grant and aid expenditures by public health district from FY25. We have a range here of around $4.5 million from our Dublin district to $13.4 million in the Gwinnett, Newton, Rockdale district, with median general grant and aid expenses being around $11 million. The dominant cost driver for general grant and aid is personal services expenses associated with implementing public health services at the local level. Finally, we have programmatic grant and aid. Programmatic grant and aid expenses equal $201 million in FY25. Programmatic grant and aid funds are directed for the provision of specific program services, such as our perinatal home visiting program or HIV prevention. Approximately 75% of programmatic grant and aid originated from a federal agency. Various federal agencies provide grants to DPH to target specific public health areas such as emergency preparedness or HIV treatment. And finally, in FY25, programmatic grant and aid expenses range from around $5.1 million in our Clayton County district to $15.2 million in the Waycross district, with median programmatic grant and aid expenses being around $11 million. And this concludes my presentation. I'm happy to answer any questions.
Representative Osteen?
Thank you, Chair. Can you tell me where that breakdown again of how much the county is supposed to, I think that was the general grant and aid.
Right.
Is that right? How much is the counties, they're supposed to contribute? How much?
So in total, the match requirement for the counties was around $12.2 million, and our general grant and aid that we provide is around $190 million. Counties in 2024 and FY 2024, they provided around $36.2 million above and beyond the local match requirement. And I did provide a breakdown of this information by county to Morgan. And so I'm happy to make sure y'all have that. But that is something that I did provide to Morgan, and we can get that to you.
Thank you.
I have a question. And looking at some of these graphs, I want to make sure I'm understanding the grant and aid expenditures.
Sure.
And looking at Clayton County, which was $5, and Dublin. Is this, I get your formula, but I'm trying to see and recognize comparison population wise. Each of these counties, I want to look up and say, okay, this is a district. Do you look overall at this dollar expenditure, or are we looking at it by county? And are you averaging this? Because it's such a big difference. Clayton County, and then look, Fulton County right next to it is twice.
Right.
So I'm trying to figure that out.
So, right. So the general grant and aid formula, it takes into account population and poverty statistics, and those are updated each year based on the county's population as a share of the state's total population. And poverty is also, of course, a factor in our general grant and aid formula. And I did also provide a breakout by county of our general grant and aid to Morgan. I'm happy to, follow up with you on that, but it does include the population and poverty statistics for specific counties on that document.
I get that, but I'm trying to figure out in my mind why Fulton County was so much more than Clayton County, for example. And looking at the areas around it, the similarities? It just seemed like a tremendous difference in the amount.
The general grant and aid formula, it only takes into account population and poverty
Okay.
figures.
Okay, thank you. Does anyone else have a question? I think we'll be milling over this for a while and may come up with some additional questions later.
Great. Okay,
Thank you very
thank
much.
you.
All right, our next presentation is going to be our panel discussion. If we could get our panel folks to come up to the table. If each one of you would take a moment and introduce yourselves, tell us a little bit about yourself, and then we will be very happy and looking forward to hear what you have to say. And we have our moderator will be Megan Andrews, if you would begin.
Yes, thanks for having us, everyone. I'm Megan Andrews. I'm the Assistant Commissioner for Policy at the Department of Health. If you don't have my info or my cell phone number, please come see me. I'm always happy to help with any constituent issues you may have, but I'll let my panelists introduce themselves. We tried to get a representative group from both the state office as well as local public health so you could hear some varying viewpoints. So why don't we start with Diane and then work our way down the table with introductions.
Hey, good afternoon. I'm Diane Durrance, and I'm the director for our Women, Children, and Nursing Services Division.
I'm Dr. Thomas Kraft, and I'm the district health director for the South Central Health District, which is centered out of Dublin, Georgia, and covers the Lawrence County and the 9 counties surrounding.
Good afternoon. I'm Dr. Zachary Taylor. I'm the District Health Director in District 2, which is sort of the northeast corner of Georgia. The district office is located in Gainesville, Georgia.
And good afternoon again. I'm Dr. Chris Rustin. I serve as the interim district health director for Fulton County.
Okay, so we're gonna do some panel questions and I'll direct them to certain team members that we want to make sure you get their perspectives. And then if we have time at the end, we'll open it up for some questions as well. So the first question is for Diane and Dr. Taylor. What are the agency's top priorities to protect and promote the health of Georgians? And what role does local public health play in making those goals a reality?
Let's start.
Okay. Okay, so the top priorities are just maintaining those core services, many of which have been highlighted already this morning, including our maternal and child health programs, our infectious disease programs that provide screening, treatment, and really important follow-up for things like tuberculosis and syphilis. Also for treatment and follow-up of vaccine preventable diseases like pertussis and measles. In our maternal programs, we have things like our breast and cervical program that provides mammograms for over 11,000 women every year that are uninsured and identifies roughly about 85 breast cancers every year. There's not another source for those services without that. I think in addition to, and where local public health comes in is the staffing to make all of the services happen. So I think in addition to these priorities, another real important role that we have is our ongoing surveillance of healthcare trends, access, and outcomes, and identifying when new services are needed and need support. I think one example of that is what's been discussed with our home visiting program for pregnant and postpartum women and their infants. One of the ways that this program kind of came about was recommendations from the Maternal Mortality Review Committee in identifying some health outcomes in moms that we could work on. And then also the access to local prenatal care had decreased in many areas of the state. We currently have 67 birthing facilities in Georgia since we've had 15 rural labor and delivery closures in the last 11 years. So when those labor and deliveries close, oftentimes OB services decrease in those areas as well. So we've got maternal outcomes that aren't optimal in some places, and then we also have less access to those services for good outcomes. And so the home visiting program is one way we can't replace all the providers, or deliver the babies, but we can increase the clinical encounters and assessments that happen with pregnant women, postpartum women, and their families. So that's just one example of something that we do to monitor the priority services.
So at the local level, the public health is really, you're talking about two things. What happens at the health department, which is typically clinical services, and then our environmental health programs. And they're both designed to both prevent and protect the public from disease. Our environmental health program tries to prevent and protect the public from, diseases caused by human waste by making sure that it's appropriately disposed of. Our foodborne illnesses that may occur from inappropriate processes in our restaurants. What could happen in our tourist courts if they're not well maintained. And certainly if public swimming pools are not appropriately maintained, the spread of disease that could occur. Dr. Toomey talked about population health. Well, the local health department is where that population health impacts the individual, because we take care of individuals. So we provide a number of services there that continue to protect and prevent disease. Obviously, vaccinations of individuals is a very important part of that. But it doesn't happen just at our local health departments. We also go out in our communities to vaccinate people in local businesses, in our senior centers, our nursing homes, and our schools. We even have, Diane mentioned home visiting for our prenatal program, but our nurses go out to homebound persons in the community to provide them with vaccines because they can't get into the health department or to their physician's office to do that. We have cancer prevention for women. That's breast and cervical cancer prevention programs. Very important. These are for lower income women who can't afford to have a mammogram or may not be able to follow up an abnormal pap smear. We provide those services for those women. We have family planning, obviously, to help prevent unplanned pregnancies. So we have a very robust family planning program. As Dr. Toomey mentioned, now our RNs, who are expanded role nurses, they can be trained and they're able to put in Nexplanon, which is an implantable, long-acting, reversible contraceptive. Our APRNs are able to do the IUDs, and obviously we prescribe other parts of other things for family planning. And then finally, I think in addition to our child services, where we do the screenings for children, obviously provide the vaccinations for them, we have our control of communicable diseases. This is primarily sexually transmitted diseases and tuberculosis. And so we diagnose, we treat, we follow up when necessary. For a disease like tuberculosis, which requires a long time for treatment and several medications which must be taken correctly to prevent the emergence of drug resistance. We provide directly observed therapy. So that means that the person is being observed either by a nurse, or in some cases we have DOT workers or persons who are able to go out and deliver that therapy to the patient. So.
Thank you all. So for the next question, you heard a little bit from our CFO, Will Bell, on the various funding streams. So general grant and aid is the most flexible funding source that the local health departments receive. They don't have to be for specific programs. So with that in mind, we wanted to ask Dr. Rustin as well as Dr. Kraft this next question. So you get both a urban Fulton County perspective as well as a Dublin District perspective. So understanding that general grant and aid is the most flexible of the funding received by local public health, what are some of the biggest cost drivers that general grant is spent on at the local level?
I would assume there are a lot of similarities for the way this is. I would assume there's a lot of similarity for the ways that general grant and aid is spent from district to district. In my health district, we see that the largest ways that grant and aid is spent is probably district salaries and fringe. That's probably biggest in each of the districts. We spend a fair amount of money on biologicals and pharmaceuticals, even though some of our vaccines are provided, others have to be bought for private pay. We spend a fair amount on equipment. There's cost for each health department on indirect costs, which supports the district office and those services that the district office provides on economies of scale, so that each health department, as Chris Rustin, I think, mentioned earlier, doesn't have to have their own IT person, their own finance person, their own HR department. So that's a cost to the health departments. And of course, there are other supplies and materials. For some health departments, utilities can be a big cost. But for other health departments, that's part of what the county covers. So it just really depends on the individual county, but certainly utilities, especially in hot South Georgia, can be considerable. And then my district is the smallest and most rural. There's been some talk of electronic medical records and that sort of thing. Mine is the last district to not have an electronic medical record. So we're excited about that in my district, but we've not had the costs that some districts have to support that. And we'll of course have to plan for that. We're also planning to update HR and payroll software and things along those lines. So there'll be additional costs that come with implementing and then maintaining that type of software as well. So those are kind of some of the bigger costs in our health district for grant and aid.
I have a couple questions. We're going to go ahead and ask them now, if I could.
That's fine.
And it has to do with that. When you say you're purchasing, are you getting funds from the state, or does the local have to decide, I'm going to purchase this level of medical records, or is it going to come from a central location?
That'd be better coming from.
I've got questions too. When you order your medications that you may dispense, do you get to take advantage of 340B?
Yes.
Absolutely. I would hope that would be a big piece of it. Go ahead, if you could follow up on the purchasing.
Sure. So for the electronic medical record system, DPH is using federally received grant funds. It's called an infrastructure grant to pay for the system, the build out of the system, the rollout of the system. It'll be fully covered by DPH. And the plan is that they'll cover it for a couple of years after the rollout. There will be discussions about cost sharing for maintenance and operation once the system is fully stabilized. We're not quite there yet, so we don't know what that cost is. But when we RFP'd this project, the goal is that we wanted the cost to be less than what the districts are currently paying for their own independent EMR by sharing the cost across the state versus individual contracts for 18 districts. So that's the plan as far as that cost goes.
Do you, bill for your services? Do you bill insurance companies? Do you have a system that everybody uses the same thing to be able to bill? And does the money get returned to the local department or does it go to the state?
So currently we do bill for services. It's different in every district because right now every district has a different type of system or software that they're using. But there is the ability for health departments to bill insurances, Medicaid, there's reimbursement rates for Medicaid. Those funds stay within the health department to be used to either expand services or continue those additional services.
I think it would be valuable for them all to be on the same thing, and then you can collect the data and we would have something to look at. And my concern is how insurance companies accept your charges and your billing, and do they pay it differently? Are there different rules by different plans? So we can get some consistency and see if there's something there we might need to do. Last is about, we talked about infections and things that you do. Are you seeing, just because I'm curious about it, measles outbreaks and COVID, it's still around. Are we seeing it to the degree that we had been in the past?
So we have, we do deal with there was recently a measles outbreak. It actually wasn't in my district, but the child sought health care in my district. So we had persons who were exposed at healthcare facilities. So what happens when we have that occur, because measles are very easily transmitted between human to human. What we do is we identify everyone that's been exposed. We find out their vaccination status. If they've not been vaccinated, we offer vaccination, or we can also offer immune globulin to prevent them from developing measles disease. And those persons might have to be quarantined for a period of time until we make sure that they don't develop measles and then spread it beyond that. So yes, we do those types of investigations. And for other vaccine preventable diseases too, as well as investigating foodborne outbreaks, as Dr. Toomey described the norovirus outbreak.
And you each talked about the folks that work for you, and are you having the same problems that we see across the state? Staffing, is that an issue for you? Is it related to pay or just finding them, or what are you seeing out there?
Yes, we have huge issues, especially nurses. There's a lot of competition. For instance, in Hall County, we have a large hospital system called Northeast Georgia Health Systems. They start their new nurses just out of school at a higher rate than we pay our experienced nurses. And so there's a lot of competition for nurses within our areas. Environmentalists are hard to find because there's no school for being an environmentalist. It takes, we require certain degrees, science-based degrees, but then it takes at least a year, usually more than that, 2 years maybe, for that person to actually be able to do the job of being an environmentalist, because there's no other place they're taught how to do it than on the job. And then nutritionists are hard for us to find also.
Thank you. Representative Sharper, you have a question?
Yeah, thank you, Chairman. I was talking about the EMR system, and we know the biggest thing is get the continuity throughout the state. And also we're looking more to get the real-time results, like the person goes to that, facility and they show up there a matter of time, it's like an hour maybe, that they can say, okay, that person's been here, been there. How does GRITS play into this whole system? Because I know you're starting some, you got the pilot, but the GRITS program being able to go throughout pharmacies to get information. How's all that play together?
Yeah, so GRITS, for those that don't know, it's the Georgia Registry of Immunization Transaction Services. It's essentially the immunization system, how we collect all of our immunization data that we administer in the health department. It's used by pediatricians. It's not just a public health system. It's used very broadly for vaccines. That system, just like currently it's set up, will be interfaced with the new EMR, because we want the data to be shared across the board from the GRIT system. So what will happen is if you get a you come in to get a vaccine, when your information's entered into the chart, it will auto-populate into the grid system so that you have basically bidirectional data sharing between those systems.
Okay, thank you. And anybody can answer this part. You know, we have data which we get through all the services through the health departments. All right, we got all the data that's coming in because I know a lot of grants and things is determined by your actual data. And on this side, we have research, things that we're looking for, things to make things better, how we can respond, you know, in better ways to serve the community. Where do you feel we are on research and data? We'll put data on this hand, okay? Data and research from a 1 to 10 as a state, where do you think we are? Being better.
Well, on the data side, definitely, I think, you know, we're on the higher end of that scale. Our health departments collect a tremendous amount of data, and it's analyzed. The data is entered into the various systems, which eventually go to our state office, our epidemiology office, and so they're able to analyze that data and slice and dice it in different ways to evaluate trends, to evaluate outcomes, and those types of things. On the research side, I don't know if I could put a number on it. We do partner with various institutions on research. There's a process, though, for that. Institutions that want to use our data for research are required to submit a request for that data because we need to make sure it's appropriate, number one, and that it meets statutory requirements. Some of our programs have statutory requirements on how that data can be used and shared. And so we require them to come through DPH so we can ensure that whatever way that they're using that data for research is meets those statutory requirements, and it's a study that will benefit Georgia and our citizens as a whole.
Okay, because I know either way, you know, when you're talking about data and research, there's different softwares, and it's good to know where we are with our softwares and how we're, you know, comparing to getting the information that we need for any grants or any just partnerships overall.
Right.
All right, thank you.
You're welcome.
Chairman Hatchett?
So I don't know where this question goes, but so with the EMR, I think the EMR ties all this, but right now we've got 159 separate health departments that operate from a business standpoint separately, and they get different reimbursements. They get different reimbursements. They have to pay different amounts for different vaccines. Am I right? Sort of? No? Okay.
Not on the vaccine.
So will the EMR, from a policy standpoint, they're operating as one, but from a business standpoint, will the EMR allow possible statewide agreements for, you know, anything, make us operate more as a one business entity to hopefully get better reimbursements, better cost on things?
So I think that our structure, the way we're currently structured in statute, would create some limitations on that. However, once we start collecting the data, we'll have a better picture of what we can and can't do as far as that goes. Right now, we don't know because everything is independent and the data doesn't come to DPH. This new EMR system is going to have a data analytics part of it where DPH can essentially monitor what's happening in real time, as I think was mentioned earlier. We don't have that capability now. So it is a possibility in the future. The structure, though, may limit statewide decisions being made because the boards of health are currently independent of DPH.
And I'll jump in to provide an example that I think will give some good context. So for insurance reimbursement, for example, if the state were to negotiate contracts with insurance companies as far as reimbursement rates go on behalf of all of the counties, the clinical person that is actually providing the service to the patient that we're trying to get reimbursed for is not a DPH employee. They're a county board of health employee, which may lead into some challenges with an insurance company not wanting to reimburse the services because it's not a contracted provider. They're not contracted with the county, they're contracted with the state. So that when he's referring to the structural challenges, that's an example of what may be an issue.
Great lawyer, though. I'm sure you can figure it out.
I have lots of friends that
So I
can help
got-
fix it over here.
I got another question. So we've talked, and this, please don't take this wrong, any women in the room. We've talked about women's health, a lot of things, and I love women, and women are very important. But do we do screenings for men for prostate cancer and things like that? Do we do that? And colon cancer, colorectal cancer, which is everybody.
So we don't screen men for cancers, prostate cancer, colon cancer. We don't screen women for colon cancer, as a matter of fact. Our primary interaction with men occurs through immunizations, evaluation for STDs and treatment and of tuberculosis. So in a sense, and I think this is a challenge for health departments. If a man walks in a health department, he's going to stand out because primarily our patient population are women and children. It is a problem, and I think that it does tend to keep them away. But we follow what at local level we follow where we get our funding. So that's that drives the services that we provide. We don't get funding to screen for prostate cancer or for or any other type of cancer other than the breast and cervical cancer program. So
Personally prefer the PSA, but we won't go there.
I will say from the standpoint of being a smaller rural district where many of my counties don't have providers, that we do have some leeway with use of nurse practitioners to do some small amount of maybe a safety net, catch net for providing care in areas that don't have access to care. And so in a couple of my smaller counties, I do use nurse practitioners to provide some of those services, although there's no way for one person to really take care of a whole county. And then we also will provide services like employment physicals and or DOT physicals, and you have to get certified to do that. But it keeps people from driving 2 or 3 counties over to have those kind of services provided. So they're available, but Zach is right. A lot of it just depends on funding. But we do have diabetes and hypertension protocols, and I do have men that walk into our health departments just for their diabetes and hypertension care because we're the only source of care in town.
Thank you. Okay, Representative Osteen.
Thank you, Chair. I'm just going to make 3 observations. Maybe it'll go on record that we need to look at. One, we obviously need to look at pay for your nurses and your providers, right? That's one of the things we need to look at. I'm talking about the elephant in the room. I mean, I know but we need to do this. But okay, I'm getting there. 2, maybe scope of practice for practitioners that are in these rural counties. 3, maybe we need to look at the structure of how the whole system is set up and figure something out with that, right? Because that's what it sounds like with the billing issues, with pay. A lot of them is services. A lot of it is the structure. When you pointed out that something hadn't been changed since 1972, we haven't looked at that rubric since 1972. That's a glaring. I'm 55. I was born in 70. I know how that's 53 years. We haven't looked at that. So those 3 things I think we need to look at. Thank you.
Thank you for sharing that. Again, as we're offering advice, as you're looking for your EMR service, make sure it's something that would be compatible with the billing system. So I'm sure you're looking at all that, but that's good advice. So they tie together. You have your accounts receivable and accounts payable. Okay, sorry, but we wanted to get those questions in. I know you have another Questions?
Oh, yeah.
Can I follow up one last thing? This is
Okay.
about the electronic health record. So while we do have data that's already submitted by the districts and the county health departments now, it's only data that we've asked for that's been identified, and it's very limiting. So we can count certain things, and kind of to your point, Representative, as an example, our home visiting program now, we have to do actually paper record or hard copy audits or go into individual electronic systems in every one of those districts and look at individual patients to be able to put any kind of quality, to the data. Like we can't, if we just pulled it out of their system, we can't tie the mama to a baby. So we're looking at everything as separate things. We can't look at one patient and say, you're enrolled in this home visiting program, and as a result, your infant was born full term, weighing this amount, and we can track those kind of outcomes. So having access readily to the whole system for the state will give us a lot more of that kind of a picture to be able to know what we've got in place.
I will add, we as a state have let you be 50 years behind, and we can't do that anymore. Okay, go ahead.
Yeah. I'm actually going to skip around a little bit, so y'all forgive me because I think we covered a couple things, but I did want to go back to workforce. And Chris, I'm actually going to toss this question to you because I think it's also an important thing that we've discussed over many years, is the challenges with career ladders within public health because of our structure. And how an individual employee can progress from entry level up to a leadership role, and what some of the challenges are with that as far as like workforce development.
Sure. Obviously, we have a variety of positions in public health. I'll highlight three: our nutritionist, our environmental health staff, and our public health nursing. The challenges on the recruiting side vary around the state, and you would think that in a large urban county where there's a lot of people that we would have a very easy time recruiting, but with nursing and environmental health specifically, there is so many other opportunities in a large urban area that impacts recruitment. And so we are competing against the hospital systems, the private sector. Restaurant inspectors are also employed by the corporate restaurants. They have their own internal staff, and they love hiring our staff. We train them, they hire them, and they double their salary. And so that's what happens in a lot of regards to our staff. We do have career ladders for nursing, our epidemiologist, our environmental health staff. We don't have career ladders for every position, but the career ladders are what I would call static career ladders, meaning when we establish them, we're basing it on market rates at that time. Some of our career ladders are already 3, 5, 10 years old. And so obviously keeping those career ladders at market rate requires additional funding to do that, because we're basing it off the funding we have at a given point of time. I will say, and I want to thank the legislator and thank the governor's office for the funding that we have received. You've all made investments especially in environmental health, nursing, and epidemiology, and it has helped with our recruitment efforts and our retention efforts. But we do still see large turnover rates, and especially in the nursing and environmental health areas. Last year, the turnover rate for environmental health was around 13%. Now that's a lot, but that has decreased. We are seeing a downward trend in retaining staff. But the market drivers that are essentially taking our staff away are things like the private sector often offering remote work opportunities. Our services are not remote. We are in facilities. You can't do that from home. And so that's not a benefit we can typically offer, because we need our staff out in the field, out in the community, in those facilities, interacting with the public. But those are things that we do compete against. Sometimes it's not always salary. It's the other things that come along with a private sector position. So we have made a lot of effort to improve our career ladders. But obviously, as the market, as our economy grows so fast and so rapidly, we're to be competitive, we're going to have to continue improving those career ladders. One thing that we have worked on doing, and one thing that I've seen in my career, is you tend to retain public health professionals from the areas that they lived in or grew up in. A lot of those professionals, if they go to a regional university and they want to work from home, they may end up at a health department, and they're kind of homegrown, so to speak. We have started conversations with the technical colleges and the more regional universities to try to develop a more pipeline of nurses, environmental health staff. There is only one environmental health degree program in the state of Georgia, and it's a UGA bachelor degree program. There's a lot of master's programs in environmental health, but not traditional undergraduate degrees. So we typically hire for environmental health individuals with Bachelor of Science degrees, but not necessarily a Bachelor of Environmental Health Science. And so there's a lot of on-the-job training, as Dr. Taylor had mentioned. But I think working with those regional universities and technical colleges to try to help us build that pipeline may be beneficial. But obviously, I'm a realist. I've been around long enough to know that in government, there's optimal, there's like perfect highest salaries, and then there's the lowest. Somewhere in between is where we need to be. And I think to be competitive, we've got to really take a look at those career ladders and focus some efforts on those to try to retain, because the retention cost is extremely expensive. When you spend a year training a nurse or a year training an environmental health specialist, you are also paying for the cost of that trainer because you're taking them away from their normal job. And so the cost, when we've looked at it over time, it's a lot more expensive to train and lose people than it is to retain them. It's cheaper to retain them in the long term. Plus, you end up with a more stable workforce that knows the job and hopefully is more community oriented for our services. And I'm happy to let others on the committee chime in.
I'll just reiterate what you said about retention and in a rural environment where the pool of people to hire is smaller. Finding a replacement is difficult, but the cost of having to retrain someone over the course of a year is almost devastating sometimes to a one or two nurse health department. Earlier today, Nexplanon was mentioned as or the long-acting contraceptives are inserted. We talked about how that was able to be done. In my 10-county district, our largest county, Lawrence, was the only health department that could provide those services for the longest period of time until we got a protocol that nurses could work under and do that. Now it's available in all 10 health departments. But there's training involved in that, and nurses that come from hospitals or nurses that come from dialysis centers or nurses that come from elsewhere, they don't have those skills. So even if you hire from outside of public health, you still have to go through protocol training of not just that protocol, but all the hypertension protocols and diabetes protocols and infectious disease protocols, because our nurses operate in a more clinical, they practice the clinical skills that in a hospital the doctor provides, and nurses there follow orders more than they make clinical assessments and do things. And you have to teach people to do that. And that takes time. So every time we turn over a nurse, we lose a long period of time where those skills are not available in a health department. And we have to shift and shuffle and provide it 2 days a week until we can get those people provided. So the career ladders are important. And I agree, in our district, it's nurses and environmentalists and nutritionists primarily, but other skills as well.
Thank you. Chairman Cooper?
Thank you, Madam Chair. Just have a quick question to the two health directors. Are you MDs or PhDs?
I'm medical doctor and so is Thomas.
Because I wonder, finding somebody that can fill your position and understand public health is so unusual that we had to change the rules that said you didn't necessarily have to be an MD. And I just wonder how that will, when you're training, what impact that's going to have in the future when it's, I know you have to have a medical director at the local level if you do that, if you don't have an MD, but I just wonder how that'll impact that training issue going forward. So I guess we're going to find out.
Well, I will say
Change that
Dr.
law.
Rustin is our first non-MD health director. He's the interim health director of Fulton County right now with the chief medical officer. So he's the first one of your bill being put into practice. Yeah.
Well, yes. Yeah. 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 It's, I think, to be determined, but I will say that we would rely heavily on our clinical nurse director, who generally in every district's an expert in protocols. Fulton has a chief medical officer on staff. And that was obviously the idea of the bill, is a non-MD could have a CMO or a contracted physician. But I think a lot of the training is going to occur by probably the nurse director, with some training through the either the health director, who's an MD, or a chief medical officer, but it's to be determined.
Really hands-on training from the state on issues like that, or is it still hands-off? I will train our own people.
No, we actually do provide a lot of the training.
Okay.
Yeah.
Okay.
From the,
Diane oversees the nursing program, which helps write all the protocols and
yeah, a very extensive training process.
Thank you very much. You all have brought a lot of insight to us today. We appreciate all that you've done. Thank you so much.
Thank you.
And we have our next speaker will be Allison Chamberlain. She's fumbling with this. Does she have to do something, or do we have to do anything? In the folder?
Yeah.
Is yours? Yes. Where's the full screen little button? Oh, so this isn't a PowerPoint.
Thank you. If you will introduce yourself.
Okay, tonight, so I'll just present like this. Okay. Thank you all for having me this afternoon. I really appreciate it. This is I'm Allison Chamberlain. I'm from Emory University in the Rollins School of Public Health. This is my first time presenting to a legislative body, so this is exciting for me. So thank you for having me. Today I'm going to be a lot of what you've already spoken about with the previous speakers and the panel. I'm going to touch on and elaborate on a little bit. And I'll first talk a little bit about me. I am a research associate professor at the Rollins School of Public Health. And I do hold a number of roles there, but the one I kind of wanted to focus in on here was the third bullet, when I served as an epidemiology consultant to the Fulton County Board of Health for 7 years. And that was a part-time consultancy. I was faculty at Rollins at the time, but I wasn't loving faculty life and really wanted to have an experience that connected my work in academia to practice somehow. At the time, Dr. Toomey was the district health director at Fulton County and took a chance on me and said, come down, I'd be happy to sort of show you around and give you some opportunities to learn about local public health. And I stayed there for 7 years in a part-time capacity. And it was the most kind of formative experience for me to really understand what goes on inside of a local district health department and the things that they do well, the needs that they have, the types of people that work there, and the breadth of what a large district health office can do here in Georgia. That said, I've never worked in a smaller district office. So as you heard at the beginning of today, you've seen one health district office, you've seen one. So I do understand that intimately, but I really loved my experience at the Fulton County Board of Health. Okay. Another thing I'll mention here is that I have also served for the last couple of years on the State Preventive Health Advisory Committee, which Dr. Toomey had appointed me to in 2023. And that really kind of gave me an insight into the federal allocations that come from the Preventive Health Services Block Grant that Georgia does receive from the CDC. So today I'm going to be talking, I'm particularly interested and knowledgeable about public health workforce. And as an epidemiologist, that expertise is traditionally in epidemiology, but having had a glimpse inside of a health department, I can see where, there's needs across the board. Some great things for Georgia public health. And I'll talk more about the first bullet here. In 2020, we launched the Rollins Epidemiology Fellowship Program, and that is a workforce generating program for epidemiologists across the state, and I'll talk more about that. We've also, in 2023, House Bill 911, which was already mentioned just previously, appropriated an additional $16 million to state and county public health departments to increase salaries to address that really critical issue of recruitment and retention. That was fantastic. In 2024, Georgia Bill SB 293, again, broadened the degree requirements for district health directors to give the state leeway to find the most talented people to lead district health offices if an MD isn't available or selected. So again, we have a wonderful number of MDs who do lead our district health offices, but that gives us an opportunity to have other folks with a lot of experience, deep experience, also be able to lead district health offices. And then in fiscal year 2026 coming up, there is a new $600,000 for 6 new perinatal regional centers. And that really goes back to kind of the state's concerted efforts to expand perinatal services around the state in light of those obstetric care deserts that we've already talked about. So I wanted to start my presentation off with some highlights because a lot of good things have happened in recent years. This is very small. I'm sorry, it's so small, but in preparing for this, I kind of wanted to take a look at Georgia's public health budget and looking at, what was allocated in fiscal year 25 versus fiscal year 26, and just kind of wrap my own head around that. And I got to did this kind of bird's eye view of the big categories. And, they're really historically been focused on, and as they should, public health problems that Georgians face. But the one thing that, in thinking about problems that are so important, but it's really the people running these programs that solve the problems. And so we've really, I think, reinforced that a lot with the comments today. But that's something that I truly feel passionately about because it is the public health staff that are ones that are putting your dollars into work. So again, I don't want to spend too much time on this, but this was my way of also talking about who works inside health district offices. So you have the district health director. If in some cases you have a chief medical officer, or medical director, especially in a case where you definitely want to have that MD there. And then there's division leads. Examples include those who lead epidemiology divisions, environmental health, clinical preventive health services, public health preparedness, and then all the program staff that report up to those division managers. Some of the most influential and important roles that I've seen to date inside of a district health office include the district health director, him or herself, public health nurses, and epidemiologists. And in my learning today, environmental health folks too. And to talk a little bit more about what they each do, I think that gives a good picture and kind of ties to the things that the state has already done to help support these important roles. District health directors, they lead district health offices, they oversee the programs, they manage budgets, they sign necessary contracts, they liaise with the boards of health, and they communicate, most importantly, with the public. And so why they're important is, they're really the ultimate face of the health department to the public, and they set the culture within a district health office. And that was, again, tying back to what's already been done. That was why Georgia Bill SB 293 was so important, to really broaden that eligibility to be able to have the best folks in those roles as possible. Public health nurses. Again, we've talked a lot about this already. They provide immunizations. They staff the Babies Can't Wait program. They test for HIV, other sexually transmitted infections. Things we haven't delved too much into is that, they lead dispensing activities for emergencies, or they help staff shelters when we welcome folks from the coast for hurricane evacuation and other reasons that we open shelters. And, why are they important? Well, without public health nurses, you don't have public health. And that's really, I want to emphasize that without public health nurses, you don't have public health. And they're really, really vital. Epidemiologists. We track cases of reportable diseases. We investigate those outbreaks. We interview the people with the infectious diseases to get more information. We provide guidance on limiting disease spread, create disease summary reports for you all, for the public, for district health directors, and provide education sessions to communities. why epidemiologists are important. We prepare and track the statistics on disease threats, and educate all sorts of constituencies on prevention. So that's kind of a glimpse into the roles that I've found to be sort of most essential in some of these district health offices. I'll pivot now to talking about what could be, one creative solution, because this has been a program that has been so fun to start and run. At the height of the pandemic, I was sitting inside the Fulton County Board of Health, and I could clearly see that there weren't enough epidemiologists to handle the threat at hand. And through a, kind of a wonderful discussion with Dr. Toomey and other leadership at DPH, trying to figure out a creative way to infuse more talent into the epidemiology workforce quickly was something that, I thought, gosh, we could really leverage some of the sort of resources at Emory University to try to assist in this space. And through a wonderfully generous grant from the Woodruff Foundation, the Robert Woodruff Foundation, we were able to establish the Emory COVID-19 Response Collaborative, and within that, this Rollins Epidemiology Fellowship Program. And this is a 2-year service learning opportunity for early career epidemiologists, graduates with master's degrees in public health from around the country, not just Emory, can apply to this program to have a 2-year service learning opportunity in a district health office in Georgia. The vision of this program is to support new epidemiologists and increase epidemiologic capacity to serve Georgia communities. So here's a map of the 74 fellows that we've placed so far across the 6 cohorts that we have hired. A cohort ranges between 9 and about 15 in any given year, and we recruit yearly for this program. And what is neat about this program is that they're hired by us at Emory, but the final selection is from the selection committee at a district health office. So they make the final determination of the applicants we receive. We tee up a great group for them, and they do the final interviews and make the selections. The best part about this program is that, we've had fellows in, across the state, and they have had really meaningful experiences, both in, metro area, urban areas, as well as rural areas. The main programmatic components of this program are to give these young individuals an opportunity to learn the ropes as a level 1 epidemiology hire. So to reference the sort of career ladder within epidemiology, they start at the sort of the lowest level. But they're there for 2 years, which really gives health departments the opportunity to invest in them and to get the best out of them, but without a lot of commitment in terms of, if it doesn't work out well, there's no requirement to hire them at the end. But if they're great, they just invested 2 years in them, and then they can come on board. So this is just the map, but how have we done in terms of our goal of contributing to the public health workforce? We've had 4 cohorts of our 6 graduate so far. And of the 44 graduated fellows, over half have stayed in state and local public health in that first job after they graduate. Today, our fellows and fellow alumni comprise over a third of all master's level full-time epidemiologists practicing at district level epi divisions in Georgia. And then where are they going 1 year after they graduate? Are they still sticking around? So of the fellows who've achieved 1 year post-graduation of our fellowship, 24 or 50% are still in state and local public health. So when we talk about retention, this is a really good program to sort of infuse early career folks into, a very different work culture than what maybe they've experienced in academia to date, but do it sort of in a soft way, kind of holding their hand into this area and having them get their feet on the ground and really train intimately in their communities with the hopes of keeping the spark alive, and that they will be able to remain excited about working in state or local public health. So I've talked a lot about workforce, but I wanted to sort of make kind of another sort of broader people program connection for you all. And that's kind of using a syphilis example. Syphilis is a sexually transmitted infection caused by a bacteria. It has multiple stages of, of symptoms that if you don't catch it early, it can progress to more severe disease down the line. But if you do catch it early and provide antibiotics, then someone can be treated and cured from syphilis. Cases have been increasing in Georgia since 2018 in both rural and urban settings. Among babies, congenital syphilis is the biggest concern because it can lead to low birth weight, premature birth, and sometimes even death, or even if the child lives, it can have a lot of developmental disabilities down the line. So how do we know about these cases? Well, syphilis is a reportable disease. So when labs and hospitals test for syphilis and one comes back positive, that's reported to health departments, and epidemiologists are the folks who track those cases. Public health nurses often encounter and treat the most at-risk populations for syphilis, those low resourced individuals. Not everyone who has syphilis is a low resource individual, but they often encounter public health nurses. Catching and treating cases early is critical, and that's one of the sort of linking back to another great thing that the state has done in terms of Senate Bill 46, which required prenatal care providers to test for pregnant women for syphilis. So, how can we kind of like accelerate the ability to, find and treat these women, especially, or any individual with syphilis, but these women and specifically early? And that's where, we talk about kind of connecting people and programs. So you have women of childbearing age with syphilis. They actually get, noticed by the epidemiologists, but they also might connect with public health nurses. Public health nurses are also talking to other at-risk individuals for syphilis. And, thinking about, how can we accelerate this a little bit more, even, using prenatal home visiting or even, virtual visiting via the regional perinatal centers can really help us tackle this problem even more. So I give you this example because there's a lot of components that we have working for us here in Georgia, and putting them all together in creative ways can really, accelerate the good that we're able to do. So I'm just going to, this is, I think, my last slide, but, think workforce. Every dollar spent for Georgia public health is a dollar well spent, but people are the things that get the work done. As federal appropriations decline, state investments become absolutely critical. Public health services keep people out of hospitals. And exactly which investments, in this sort of trying to financial time are more or less important than others, that's hard for me or any of us to say because, diabetes prevention programs or cardiovascular prevention programs or epidemiology programs, they're all important. But it's the workforce that makes the difference to the success of any program. So if we're not moving the needle on health outcomes, consider the health of the public health workforce, and that creative solutions like the Rollins Epidemiology Fellowship Program, we have examples of these. And if we can leverage those examples in ways that make it work for other staff types, that would be fantastic. And it's great to hear that Dr. Toomey and her team are already talking to technical colleges that that train nurses, because this model could really maybe help that a lot. One of the things in preparing for this talk that I was educating myself on about public health nursing is that with these sort of more, what's the term, like advanced practice, the nurses that expanded role nurses, that can be flipped on its head for a really eager young nurse. They would be able to do things maybe out in the field as a public health nurse that they wouldn't necessarily have the opportunity to do when working in a hospital. So when you have that little kind of window there, you can turn that on its head and make it attractive to some of the talent coming out of nursing programs. So just keep that in mind, because there's a lot of good things that nurses can get, that are able to do in local public health nursing that you don't really necessarily see or are able to do within a hospital setting. So with that, I'll end, and I'm happy to take questions.
Representative Sharper.
Thank you so much, Dr. Changer, for information in your presentation. Here on page 4, I know that's not like your specialty or what you're doing here, but as we look at this, and I want everybody to kind of look at it if you can, but we see where a lot of these line items, they're kind of like some of them are standing flat. And one that the stroke heart attack prevention that I mentioned early, we're seeing that it's staying level funded, But at the same time, that's what we're doing, you know, for all those that don't know, the diabetes and high blood pressure, those are a lot of the patients that need help. And going to Chairman Hatchett's point about things that we can do for men, you know, that program can see a lot of men, and also just the promotion of letting people know, hey, we have this program. We can help you if you don't really have the, you know, the insurance or, you know, being able to go to a personal physician. That program alone, another thing it can do is keep people from out of the ER, because that program is, I've seen the success of this program as a paramedic, seeing people have what they need and, you know, having to go to their homes and, you know, work on them. Like, hey, I'm at that program at the health department, you know, it's doing great. But I just want us to just keep that in mind, that the other things here are great, but at the same time,
Yeah.
let's see where we can kind of help that program a little bit more, I think, because it's needed, especially in some of these rural areas where you don't have, you know, the hospitals that you have.
Absolutely. Well said.
Representative Osteen?
Thank you, Chair. I'm interested in this Rollins epidemic. This is fascinating to me. I absolutely love this. So tell me what drives you. Did you say 44?
For that have stayed or that are,
How many do you have in I guess it's a 2-year cycle?
yeah, so every fellowship cohort, it ranges between 9 and about 15.
9 to
So-
15.
And that depends on, so every February, we put our call out to the districts and we say kind of raise your hand if you would like a fellow in this round. And if they do, they fill out like a very, very simple application just to give us enough content that we can then post position descriptions to recruit the actual fellow candidates. So not every cycle does a district need or want a fellow. So that's why the variation changes. Yeah.
Okay, so how do you put that out? Do you advertise it through Emory?
So we work, so the sort of the key to this program is that we have, since its inception, have worked extremely closely with the health department, and we take all of our cues on how to communicate with the districts from the state health department. And typically we have, since the program's been running since 2020, we send our solicitation out to all of our contacts that we're already working with. And usually it's the epi division directors that get the solicitation to say yay or nay for this cycle.
Okay, my little district has one person out of Bacon County, it looks like, and it's great to see.
Yeah.
But I was just asking Chairman Parrish where his district is, and he's in 6, and he doesn't have a fellow.
Yeah.
And so we're trying to figure out how to get him down in rural South Georgia.
So we have had a fellow in every single district except Augusta. And that's fine. And we're not trying to force this on any district. We're really not. I think my own personal interest is like, I would love to get all 18, but that's irrespective of the program. It's really where the districts want and need someone. Sometimes, and perhaps Augusta is, you know, just completely adequate with respect to their epidemiology capacity, and they don't need a fellow. That's fine. But we just want to supplement with, you know, fresh new talent in case the district is interested.
Thank you so much.
Yeah.
Thank you very much. I don't have any more questions. This has been very interesting, and we look to hear more about your program.
Absolutely. And we have a website. The Rollins Epidemiology Fellowship Program has a website. If you just Google that. We added a new tab this year that talks about the projects that all the fellows have done and presented at the Georgia Public Health Association or other conferences. And it gives you a glimpse into the types of things that they're doing in their districts.
Thank you very much.
Yep.
Our next presenter will be Carolyn Mullen.
Hi, everyone.
Thank you. And is she on Zoom? Thank you.
Yes, I'm on Zoom.
Okay. Thank you. Please begin your presentation.
Wonderful. Thank you all so much for the opportunity to present and be with you today. I'm so honored to be here. My name is Carolyn Mullen. I'm the Senior Vice President of Government Affairs and Public Relations at the Association of State and Territorial Health Officials. I've been working in budget and appropriations for 23 years. I started my career 23 years ago working for the chairman of the Senate Appropriations Committee that funds public health programs. This really is my area of expertise. A little bit about ASCO. We are the nonpartisan nonprofit association founded in 1942. We represent states, territories, freely associated states, and Washington, D.C. It's a forum for our members to come together, share what's happening, share best practices. And my role with the association is to share what's happening here in Washington, to try to provide advance notice for our members, because I know many health departments, all health departments rely on federal funding. So any advance notice that I can provide with my expertise can help navigate what is a very uncertain federal funding environment. I'm going to walk you through the federal appropriations process. So the federal fiscal year starts on October 1. We are currently in fiscal year 2025. Congress is working on their annual appropriations bills right now. So typically, a president will propose a budget in early February. President Trump and his administration did propose their budget. And then Congress has the authority to accept, reject, or modify that budget proposal. So President Trump transmitted his budget to Congress. Congress began their work developing the bills. And then we have full committee and subcommittee markups. So the Senate has already marked up their version of the appropriation bill. This bill provides funding for CDC, HRSA, SAMHSA. It was widely bipartisan. It passed out of committee by a vote of 26-3. This legislation largely rejected President Trump's proposals to consolidate or reorganize or eliminate many programs. And the House is slated to mark up their version of the bill sometime in early September. After the various houses mark up the bills, they move to the floor for an amendment process, and then you have a conference report, and then the president signs it into law, hopefully before the start of the fiscal year. So if you're looking at this chart, you're like, wow, there's a lot of bubbles that need to be filled in. That is indeed the case. Congress has been delayed in their work this year, so we're currently at the subcommittee and full committee markup. It's our hope that they will approve a funding bill before the end of the year. Otherwise, we will face a federal government shutdown. So when negotiations break down with Congress, they will approve what's known as a continuing resolution to fund the federal government at current levels. All appropriation bills passing the Senate need 60 votes, which means that appropriations bills must be bipartisan. And sometimes, because they're unable to complete their work on annual bills, they'll pass a short-term continuing resolution to allow more time for negotiations. But in recent years, we've seen Congress use continuing resolutions a lot. And we are currently operating under a continuing resolution right now, which means you keep current funding levels level for the fiscal year. So once Congress approves an appropriation bill, it gets signed into law. Those funds then move to the Treasury Department. Then they move to the White House Office of Management and Budget. From there, those funds get apportioned and sent to the federal agencies, and then the agencies will disperse the funding to the state in the form of grants, sometimes block grants, sometimes cooperative agreements. Where we are seeing the uncertainty right now in federal funding is because there are ongoing debates about the balance of power of the purse between the executive branch and Congress. And so over the past couple of months, we've seen a lot of uncertainty, and it is because of those debates about who controls the power of the purse that's ongoing. And it's creating an environment that is difficult to navigate. As I stated before, I've been working in this for 23 years, and it is some of the tools in the toolbox that are being used I've never experienced in my career. So we're all learning together and navigating this process. So there are some challenges that I've talked about. We do believe there's a high likelihood of a federal government shutdown starting on October 1st. Typically, what happens in government shutdowns is the administration will deem certain services essential. Usually they will release that about 24 to 48 hours before a government shutdown, no matter who is in power. It's just delayed oftentimes. For the states, when they navigate a federal government shutdown, typically it will impact those employees who may be federally funded and their ability to contact federal agencies for technical assistance. In this government shutdown, what we are concerned about is the potential for the payment management system to not be deemed essential, which could impact the ability for states to draw down for services you've already provided. So the ability basically to pay your bills on federal dollars. This is something we'll be watching very closely in the upcoming weeks. We will make sure we're communicating to our friends and colleagues at the White House that we would like the payment management system to be deemed essential, but is something we are keeping a watchful eye on. Also, in the current federal funding landscape, we are concerned about clawback of funds that may have been obligated already. President Trump signed a new executive order just 2 weeks ago, and in this executive order, he is directing federal agencies to include new language to allow the termination of grant programs for convenience, which may include if the award no longer advances agency priorities or the national interest. This would be new language inserted into grants and for the state, and again, something we're keeping our eye on as more information becomes available. We also believe that there will be more state responsibility for activities that typically were housed in the federal government. We're seeing this play out in FEMA, the Federal Emergency Management Agency, and sort of the approach the administration is taking there. We're keeping a watchful eye on how this may impact public health programs in the future. Moreover, we're seeing less federal guidance. So sometimes state statutes tie public health programs to federal guidance. And right now, some of those federal guidances are being dismantled. And so it really provides an opportunity for the states to think about how you all will work collaboratively to protect the health of your citizens in your state and your population. But I think with any new administration, new Congress, there are opportunities. I worked in this profession for a really long time. So I wanted to call your attention to some of the opportunities that I see for you all. You could potentially focus more on your state priorities and really hone in on what do you need to do as a state to protect the health of your population and promote the health of your population. Rural health, we know, is a broad bipartisan initiative, and to think creatively about how the funding coming from CMS may be utilized in your jurisdictions. This was the $50 billion that was just signed into law from the One Big Beautiful Bill Act. Maternal and child health continues to be a top priority in Congress and the administration. And also, there will be enhanced flexibility and reducing administrative burden. We know a priority will be to really assess how are these grant programs working. And trust me when I say this, there is broad bipartisan agreement across all states that they would like more flexibility of funds. It's very difficult for many states when the funding is very restrictive. It prevents the movement of dollars and people sometimes. And so there is an opportunity with this administration to talk about potentially more block grants, similar to the Title V Maternal and Child Health Block Grant, and how we can use those funds to really impact the communities that you all serve. So thank you so much for the opportunity to present today. I know I covered a lot of ground, but I'm willing to take any questions you may have and appreciate your time. I really do.
Thank you for your presentation. That is great information. I think we are all waiting to see final outcomes and what Congress does. This does gives us some insight, and we appreciate you bringing that to us. I don't see any questions for you, but thank you very much for your presentation.
You're welcome. Thank you.
Thank you. Dean, this has been a great day. We've heard a lot of good information. We will be continuing to study Georgia's public health system, how it's structured, where we can tweak it where we need to, and how we can evaluate the services for the people of Georgia. The committee will have 2 additional meetings, and we will make our findings and recommendations in a final report. And again, I thank everyone today for their attention and for your presentations, and we are adjourned.